Good afternoon to the members of the public and members of the media. And I am pleased to welcome the officials of the Ministry of Health to the 5th public meeting of the Committee on Public Administration and Appropriations of this 12th Parliament. I am Bridget Anisette George. I'm the chairman of the committee. The Committee on Public Administration and Appropriations has the mandate to consider and report to the House on A, the budgetary expenditure of government agencies to ensure that expenditure is embarked upon in accordance with parliamentary approval. B, the budgetary expenditure of government agencies as it occurs, and to keep Parliament informed of how the budget allocation is being implemented. And C, the administration of government agencies to determine hindrances to their efficiency and to make recommendations to the government for improvement of public administration. The purpose of this meeting is to examine the preparedness and response of public authorities to the COVID-19 pandemic in Trinidad and Tobago with regard to procurement and distribution of COVID-19 vaccines. The role of the committee is to assist the ministry in achieving the efficient delivery of services while ensuring that expenditure is embarked upon in accordance with parliamentary approval, and to determine the challenges being faced and possible solutions to these challenges. This meeting may be broadcast live on the Parliament's Channel 11 and Radio 105.5 FM and Parliament's YouTube channel, ParlView. Participants are asked to keep their microphones on mute until recognized by the chair. I will now ask for introductions. I will ask firstly the representatives of the Ministry of Health to introduce themselves, and this will be followed by members of the committee. So I'll invite the CEO to introduce himself, and then he will set out the order for his team.
Thank you. Good afternoon, Madam Chair. HASSELL, Permanent Secretary, Ministry of Health. I'll let the rest of the team introduce themselves.
Hi, good afternoon, Chair and members. I'm Dr. PARASRAM, Chief Medical Officer.
Good afternoon, Chair and members. Brenda Jeffers, Deputy Permanent Secretary.
Good afternoon, Chair and members. Melanie Noel, Acting Deputy Permanent Secretary.
Good day, Chair and members. Candice Alcantara, Manager Corporate Communication for the Ministry of Health.
Good afternoon, Chair and members. Anissa Dodnat-Sibu, Principal Pharmacist, Acting Ministry of Health.
Good afternoon, Chair and members. Lawrence Jason, Director of Policy Research and Planning. Thanks again.
Good afternoon, Chair. Salim Pierce, Project Manager, Ministry of Health.
Thank you very much. And then now we can turn to the members of the committee.
Good afternoon, everyone. Lakram Bodo, Vice Chairman of the committee.
Good afternoon, everyone. Wade Mark, Member.
Good afternoon, everyone. Lisa Morris-Julian, Member.
Good afternoon, everyone. Yokima Bethelmi, Member.
Hi, good afternoon, everyone. Ayana Webster-Roy, Member.
Good afternoon, everyone. Amrata Devnarayan, Member.
Good afternoon, everyone. BACCHUS, Member.
At this stage, I would like to invite the Permanent Secretary of the Ministry of Health to make a brief opening statement if he so wishes.
Thank you, Madam Chair. Good afternoon, members of the committee, fellow colleagues of the Ministry of Health, members of the viewing and listening public. Madam Chair, the Ministry is very happy to be able to discuss our response to the COVID-19 pandemic in Trinidad and Tobago with particular reference to the procurement and distribution of the COVID-19 vaccine. However, I'd like to first maybe just touch and recognize on the ministry's ongoing vaccination efforts through our expanded program on immunization, our EPI, which has allowed this country to achieve and maintain immunization coverage between 90 to 98% over the last decade. This is for vaccine-preventable diseases such as measles, mumps, rubella, poliomyelitis, tetanus, diphtheria, influenza. I think this is important so that we recognize that administration of vaccines is not new to Trinidad and Tobago and to the population at large. What makes the COVID-19 vaccine scenario different, however, has to do with the global constraints with regard to the WHO-approved vaccine manufacturers trying to satisfy a high global demand coupled with the short expiry dates for these vaccines. That adds a level of complexity to the vaccination process. With regard to the procurement of vaccines, the government has been pursuing three main options to secure WHO-approved vaccines. Very briefly, these are through the COVAX facility, with PAHO as the procurement agent, through bilateral discussions with various vaccine manufacturers, where we have NIMDEC will be acting as our procurement agency, and through the CARICOM initiative of the African Medical Supplies Platform. To date, we have been successful in having firm commitments for a total of 240,800 doses. These are 100,000 doses from China, 40,000 doses from India, and 100,800 doses through the COVAX facility, of which we received 33,600 yesterday. With regard to the actual deployment of the vaccines, the Ministry's National Vaccination Deployment Plan seeks to address the following components: identifying the priority populations using the WHO criteria, identifying the initial batch of health facilities at which we're going to commence vaccination. The issue of vaccine cold chain and logistics, which speaks to shipment, storage of the vaccines, and movement of the vaccines. Strengthen our HR capacity to ensure that there's adequate coverage for the administration of the vaccines, and developing an IT solution to track and monitor vaccine administration, which includes inventory management as well as patient management. Our plan takes into account vaccine availability, and the actual execution of our plan is continuously monitored, and it will be adjusted based on the expiry date and the quantities received of approved COVID-19 vaccines. Thank you, Madam Chair.
Thank you very much, Mr. P.S. And to start off the discussion, I think I'm just going to ask two questions, again, just maybe for context, and therefore then I'll open it up to other members of the committee. Now, I have read that WHO has certified the AstraZeneca vaccine as EUL. Maybe you can explain to the committee and for the benefit of the wider public, what does EUL, what does that stand for, and what does it mean?
Sure, thank you, Madam Chair. I will let CMO maybe speak to that. CMO?
Okay, yeah. So the terms EUL and EUA mean emergency use license and emergency use authorization, respectively. Generally speaking, WHO will give this type of license in a pandemic or emergent epidemic situation where there's, as happened in the past with Ebola, for example, and as now happening for this particular pandemic. So it's giving an emergency use authorization based on the severity of existing disease, the spread of the epidemic, and it is usually a prelude to having full license thereafter by WHO. But for the purposes of the pandemic and control of disease, you get an EUL or EUA, which is as I described before.
Okay, so thank you very much, CMO. So are there any, so what makes the difference, or are there any deficiencies or unknowns between the status of being EUL or EA and a full license?
Right, so as I said, emergency use, meaning that you can use it during an emergent situation, something that has been around in terms of phase 4. So what happens, generally speaking, the EUL in these cases would have been roughly based on the phase 3 vaccine trials, meaning that there is a control group of people that would have been tested on, for example, with the Sinopharm, for example, would have been tested in a group of people from the EUA, the United Arab Emirates, of about 40,000 people in a phase 3, and that is done to determine safety and efficacy endpoints. So beyond that, we go into a phase 4 trial. Phase 4 usually means trial in use. So what is happening now with these vaccines that are emergency use are that they're in a real world phase 4 sort of setting where we're using it in the population. What happens normally is that they follow it either for a certain length of time and or a certain number of persons being administered the vaccine, of course, across different age groups, different criteria, so that you can have that data set available to go towards a full registration beyond. So it requires sometimes time. Numbers alone is not enough, because what you have to do, for example, if you lose a pregnancy related case, for instance, if someone is vaccinated, at least you will need to have that patient deliver the baby and wait beyond that to see what would be the effect on the child, right? Sometimes developmentally, as we see with Zika, it doesn't show up for years after. So it requires some length of time down the line before you can have all the data that is required to license something beyond the EUA. And that's what gives us this whole perception that it has been done quickly. But really and truly, waiting for phase 4 for the time and the number of vaccines is what gives you that extra few years before you can give a full license.
Okay, thank you very much. And just again for context, if I understood well the opening statement of the PS, he said that so far we have confirmation of 240,800 doses, which if these are 2-shot vaccines, this will equate to about 120,400 persons. What I wanted to find out is what percentage of our population would need to be vaccinated for us to be considered having herd immunity? Secondly, so I think I should ask that first.
So yeah, so generally, as a rule of thumb, we have been using figures somewhere between 60 and 70% of the population. There's no magic number. It really depends on, we have a heterogeneous population in terms of age, in terms of types of NCDs, for example, uptake of the vaccine and the way it will behave with the immune system. So we have a range rather than a specific number. And it is based on epidemiological factors as well. So 60 to 70 is a reasonable estimate of what will be required.
Okay. And would it be fair then to say that until we get to that 60 to 70%, we would still have to follow protocols?
Certainly, I think that's a fair assumption that protocols will have to be followed until we get to a stage where you achieve herd immunity through immunity or through natural infection. In some instances, and it happened with Zika, we saw the disappearance of a pathogen from the world or from a region in a very short space of time. That can happen as well. Doesn't seem to be the case with this particular COVID-19 that will happen, but it has happened without either achieving herd immunity or otherwise.
All right, thank you very much. Member Bodo.
Thank you very much, Madam Chair. And PS, welcome to you and your team from the Ministry of Health. If I may, through you, PS, direct my first question to the CMO. And CMO, I just want to say that you look well rested. I'm sure last night you'd have gotten your first good night of sleep following the arrival of the vaccines. But my first question would be, can you share with us the expiration date of this batch of vaccines, 33,600 that arrived on our shores yesterday evening?
Yeah, so the vaccine, it was confirmed after we got it in. It was taken to C40, and they did two things right away. They confirmed that the temperature was being held within the temperature we expected to be, which was 2 to 8 degrees. And it was confirmed by looking at the charts that came to us that it was held between 2.1 and 2.3 degrees Celsius for the entire duration of the journey, which is very good in terms of temperature control. So there was no excursions of the vaccine, meaning that it is in a state of ready for use, basically. There's no issue at all. We didn't have to go back for the manufacturer. The date of expiry was also confirmed, and that is the 31st of May, 2021.
Thank you, CMO. So of course that date will drive the process forward. So the next question I want to ask, would you be in a position to state the category and the numbers of the citizens targeted to receive their vaccinations from this first batch of 33,600? Can you share that information with us?
So the two main categories we're targeting in the first instance would be healthcare workers. So we continue that away from the front, going complete the front line that we started a month or so ago, and continue into the rest of the healthcare workers as a primary group because of their high level of exposure. And then we move into the persons with NCDs over 60 years of age. So both of them concurrently. Again, in this occasion, we have noted that a large proportion of our deaths have occurred in this particular age group, and we want to protect the most vulnerable in the first instance. So those would be our two main targets with this 33,600.
Are you in a position to give us numbers with regard to each category at this time?
Yeah, so the healthcare workforce is roughly around 17,000 persons. With regards to the NCD number, I don't have a firm, I wouldn't say through the CDAP program, we have been looking at numbers just below 200,000 as a total number of people who have been part of the CDAP, for example. But those over 60 plus the CDAP will give us a higher number. So it will probably, I don't want to give a number. I'm not 100% sure of the two of them combined, what that would be like, but it would be a substantial proportion of the population probably getting into the region of about 400,000.
Yeah, so CMO, I just wanted to follow up with regards to a report that came about in Germany, and they've suspended the use of the AstraZeneca vaccine due to blood clots and so on in those under 60. Are you in a position, or what advice would you give to our citizens? Because our vaccine, if I understand correctly, is the AstraZeneca vaccine that we have at this time.
Yeah, so the reports that we have learned so far, the European Medical Association as well as the WHO are the bodies that have been looking externally into that particular cluster of diseases in Germany. They have said there was an early cluster a couple of weeks ago, which they have said there was no definitive link between the vaccine and that particular cluster of diseases. We have seen reports of 21 persons reporting thromboembolic phenomenon in Germany as well. A link has not been, a causal link hasn't been established to say that is related to the vaccines, bearing in mind that the 21 persons would have been out of a group of 2.2 million people that would have taken the AstraZeneca in Germany, just to give an idea of the proportion. So I think that works out to something like 0.00009 of that population had thromboembolic phenomenon. And of course, it's said it was the majority of them would have been in a group less than 60 years of age, predominantly female in that particular group. So it is a putative disease cluster that requires investigation before any conclusions can be drawn. But EMA and WHO has said through their age groups that the vaccine continues to be safe, and they recommend use beyond 18 years of age for the world at this point in time.
So we are going to follow that advice. This is not going to interfere with our rollout process.
At this time, unless additional information comes forth, we will maintain our strategy of 18 years and above.
CMO, I just wanted to ask, are you in a position to say how many AstraZeneca vaccines have been administered worldwide? Do you have that information?
Sure. So, yeah, in terms of the Caribbean region, because we just started, we have about 200, what I'm told is that we have 268,902 vaccines in this region. In Europe, there's of just about 12 million. So in total, there are 12,277,902 vaccines of the AstraZeneca type, which has been given worldwide.
And our batch was received from Korea, South Korea Biotech. Can you say how many of those vaccines have been administered worldwide from that particular facility?
Yeah, I was trying to get an idea of distribution from different sites, but we'll have to reach out to the company themselves to get that information. So we can provide that at a later date if we get a positive response from them.
Yeah, Madam Chair, I'll just ask one more question before I give way to other members. Same with regards to the 2,000 that we received from Barbados. I believe that perhaps 1,000 or maybe just over 1,000 vaccines would have been administered. Two questions. Has there been any severe adverse reactions administered? And again, this will speak to the follow-up process, which you might want to elucidate on going forward. That's the first question. And the second would be, have any of these candidates received their second dose? And let me just throw in a third one. Has the ministry decided on a policy in terms of the interval for the second shot, whether it's going to be 8 weeks or 12 weeks for the AstraZeneca vaccine?
Right. So so the majority of those who would have gotten, I believe it's about 1,128, if I remember right. What happens is that it is a 10-dose vial, but we were able to get a little more than 10 doses in some of the vials, which has been the case with yellow fever and other vaccines in the past. So we're able to give 1,128 persons the first dose. And of course, those persons will be given their second dose. Majority of symptoms have been very mild. Some have experienced no symptoms at all. Mild symptoms, pain at the injection site, fever, a little fatigue, most of them resolving completely within 1 or 2 days from the time of injection. Their second dose is due to start, I believe, middle of April. Some people are on the 17th to the 19th of April. So that's when their second dose is due, based on a schedule from WHO that suggests that we should use it anywhere between 8 and 12 weeks. Now, if you were following the AstraZeneca in particular, you would have noted that the manufacturer would have said in their early days of putting it out there into the world that they should go 21 to 28 days. That was the manufacturer's specification. And what happened is that a lot of the countries, because of their high rate of infection, decided to go ahead and use the entire batch as a first dose and delay the second dose to somewhere between 8 and 12 weeks. What was noted in the phase 4 trials is that the efficacy actually went up a little bit when they delayed the second dose beyond 4 weeks. And WHO has adjusted their recommendation now. So the recommendation from WHO is 8 to 12 weeks for your second dose to get your best effect. And we are trying to stick to 8 to 12 weeks. Just to say, the first dose gives you about 76% protection after the first dose. Of course, you have to wait 2 to 3 weeks post your first injection to get the response. And then if you get that dose 21 to 28 days later, it goes up a little bit to about just above 80%. Now, if you delay it to closer to 12, what happens is it goes into the 90s. So the effect is slightly different based on your second dose. But our recommendation in Trinidad for now is 8 to 12 weeks.
Chair, if I can just one more follow-up. Now, CMO, you mentioned that the ampules have 10 shots, and sometimes you can squeeze in another shot out of that. Now, in terms of the numbers, because we are rolling out bigger numbers now compared to the initial rollout, my concern would be with the issue of vaccine wastage. And I know perhaps you might go into the process and so on that you're going to use, but can you at this point state when an ampule is open and towards the end of the vaccine session, so to speak, what arrangements are going to be put in place to ensure that no dose is wasted, especially in view of the shortage worldwide?
Sure. So we have, as you know, a tried and tested process where we have multi-dose vials being used across the health system for many, many years. So we have yellow fever, which is a 10-dose vial, and other vaccines come in alternate doses, some of them 6 in a vial and that kind of thing. So generally speaking, once you puncture the ampule, you have 6 hours as to which to complete the use, otherwise you can't use it anymore. So the rule of thumb generally is you won't open a vial unless you can completely give to the entire population that is in the clinic at the point in time. So you open a vial at 3 o'clock, you will know from who is actually physically there. If they have 2 people sitting in the waiting room, it may make more sense to have those people have an appointment for the next day rather than opening a vial and wasting 8 or 9 doses. So that happens at the local level, at the health center level. They have been doing it for a long time with very little wastage from the system. And we expect to use a similar approach going forward.
Thank you, CMO. Madam Chair, I have a few questions further, but I'll give way at this point to other members.
Before CMO, may I ask this? In terms of one, you're just saying that it is now recommended that between the lapse between the first and second dose should be 8 to 12 weeks. And I've heard the Minister of Health saying that based on your program, you all intend to have utilized the whole 33,600 by, I think, about the 16th of April or something like that. Okay, or certainly within a month. So does that mean that the 33,600 doses equates to 33,600 persons or 16,800 persons?
All right, so what was said this morning, I think at the press conference, is that what we will do is probably use half of it in the first instance. As you know, as I said, the expiry date is the 31st of May. If we begin on the 6th of April, the best case scenario for a second dose will be 7 weeks, which means it falls a little bit short of what we want for optimal efficiency. So what we will do is we distribute the first 16,000. I think that's what the Honorable Minister would have said. It should take about 2 to 3 weeks to do that. Hopefully by then we will have an idea of an ETA for a second supply of AstraZeneca, and we can make a decision then based on that ETA as to if we can wait to get optimal efficiency or if we will have to give the second dose a little bit earlier to those individuals. So we'll make that decision when we get to half of the 33,600.
Thank you very much. Okay, so I now revert to the members of the committee. Member Mark.
Yeah, thank you, Madam Chair. Madam Chair, the first question I would like to ask the CMO is to just clarify for the population those who should not, may I repeat, those who should not be administered with the vaccine given certain challenges, health challenges that they may have been exposed to thus far. Can you just reiterate and outline those individuals that ought not, what I said, individuals suffering from certain challenges, health challenges, who ought not to be administered with those vaccines?
All right, so there are generally four big groups of people who should not have it based on the national policy. And that's one, for now, persons below the age of 18, we are not offering to those individuals. Persons who are pregnant or breastfeeding, persons with a history of anaphylaxis or allergic type reaction to any component of the vaccine, and those who would have had an anaphylactic or adverse reaction to the first dose when you get the first dose. There's another broad group of people, I think this is what you're alluding to, persons with HIV, for example, persons with other immunocompromised states. What we suggest is that just because you have HIV or immunocompromised state, severe cancer, for example, doesn't mean you can't have the vaccine. It may mean that you actually should get it in preference to another person. But what has to happen is there must be a clinical assessment by your attending physician. They will make the determination whether you're in a state at present to have that vaccine administered, and then, of course, give you the go-ahead to have it or not. So, for example, HIV again, your physician will look at your viral load, they will look at other clinical parameters, and they will determine if you are in a position to receive that vaccine safely. And then they will, so those fringe populations, certain populations of clinical disease, they have to have consultation with their specialist that is attending to them before they can get the go-ahead to have that vaccine, as with not only COVID, but when any other vaccine that they need to have.
Yeah, and CMO, as it relates to persons with allergies or being sensitive to allergies, how would you, or put it another way, what would be their defense mechanisms to ward off this enemy that may be coming at them, that is
right, so
the COVID-19 virus?
So the generally the mRNA vaccines are the ones that have been shown to have severe allergic reactions, meaning the Pfizer vaccine and the Moderna vaccine. This AstraZeneca has not been shown to really create any sort of allergic type reaction beyond any other vaccine. So it is not a significant concern for the AstraZeneca vaccine as it would be for Pfizer or Moderna. Possibly the mRNA formulation lends itself for some reason to creating that sort of allergic type reaction, which is listed as a possible potential side effect of those vaccines. But for AstraZeneca, having a history of allergic reactions, not to the components, but to anything else, doesn't preclude having the vaccine at this point.
The other area I wanted to raise has to do with the role of the private sector in the procurement of vaccines. And I raised this in the context of, we were told some time ago that one private sector organization offered to procure for the government some 1 million doses of vaccines for this particular virus, or to address this particular virus. I wanted to ask you, in light of the raging information that is now in circulation about counterfeit COVID vaccine in some parts of the globe, what is the ministry's recommendation as it relates to, one, the role of the private sector in procuring these vaccines, and two, what mechanisms are we putting in place to ensure that counterfeit vaccine do not penetrate our borders and end up being in the arms of the vulnerable and the marginalized and the weak?
Yeah, yes, I don't know if you want to start and I can do the second bit, but if you want to.
Sure. Madam Chair, through you. So with regard to the engagement with the private sector, the ministry is still finalizing the arrangements in terms of how we engage and to what extent we see that partnership with the private sector taking form and shape. That's where we would to private sector engagement. Let's speak to the whole issue of counterfeit vaccines and what is in place at the ministry's end to treat with the issue of counterfeit vaccines.
CEO, are you come through? And therefore we could go to the CMO?
Yes, I'm sorry, Madam Chair. I'm true, thank you, sorry.
Okay, yeah, so in terms of counterfeit vaccines, we would have had our Chemistry, Food and Drug Division is really central to the role of ensuring that products, whether it be vaccines or medications, meet a certain standard, one, in terms of importation, and of course, they have a critical role to play in post-market surveillance. With regards to vaccines, it really relies a lot on having the customs as well playing a role, so other agencies, and really Food and Drug is our main player with regard to having that intersectoral collaboration occurring. They have been meeting with all the necessary sectors to ensure that we all have our eyes and ears on the ground to ensure that really, if the vaccines do come in and that there's a process, one, to actually have a look at those vaccines to see if they are legitimate or not. And then, of course, really that we can detect it as early as possible. So I think there's a all of sector, there's an all of government, all of society approach that we need to take, because people need to recognize, one, for now, the only people that will be administering the COVID-19 vaccine is the public sector, and we'll be doing so through 21 centers. And we have gone to pains to ensure that those centers are up to standard to distribute, and not only to distribute, to actually keep a track of what vaccines come to us, how they're distributed on a daily, on a moment-to-moment basis. So we want to keep our controls as tight as we can. So if people are offered the vaccine outside of the public sector, a red flag should go off right away, because the only vaccine for COVID-19 that is given or will be given in Trinidad at this point in time will be through the public sector at those 21 sites.
Can I add that it's for free?
Certainly, yeah, there's no charge, there's no cost.
Madam Chair, can I proceed?
Excuse me, Member Mark?
Yes, no, I have some other questions. I just want to put two more questions before I pause and get back to another round. The question I'd like to pose to the CMO and the PS is whether the Ministry of Health dropped the ball as it relates to early forward planning. I have been doing my own research on this COVID-19 matter. And in the case of a country called Israel, they began to plan and engage in what they call advanced purchasing agreements since mid-2020. That's around June. We have been advised by the authorities that in the case of the Ministry of Health, we began to hold talks seriously around October of 2020 or thereabouts. But there were some preliminary discussions, as I understand it, maybe around August, September. Can you tell this committee why the Ministry of Health did not embark on earlier forward planning kind of strategy whereby we could have done some advanced purchasing agreement pending WHO approval, as the case may be, so that when we did get approval, those pharmaceutical companies would have been in a position to supply us with the relevant dosage or doses of vaccines that we require. And as we on that, Madam Chair, can I ask the CEO to indicate to this committee how many doses of vaccines we would need to order in an effort to ensure that we have adequate coverage so that this economy can begin functioning once more? That's an addendum to what I've just asked.
Madam Chair, maybe I can start and CMO can jump in afterwards. So the ministry did start, we have been planning in advance for this vaccination. The issue is, in terms of our bargaining power, we are a small state. So it is the volume we're talking about. There is a challenge, one, with regard to being able to negotiate and be in the queue with regard to the quantity of vaccines we're talking about. That's one. In fact, some manufacturers have minimum order quantities, which we just don't meet that threshold. We have been working with COVAX, and we have been progressing talks significantly with other bilateral arrangements. We're hoping to see some firm commitments coming out of that shortly. With regard to the quantity we require for herd immunity, I'll let CMO speak to that, please.
Yeah, so if we go based on our previous discussion with 60 to 70% of the population requiring to be vaccinated to get to herd immunity, we're speaking to close to just under 1 million, I would say, persons that need to be vaccinated, which if you take away those persons under 18 and you take away the pregnant patients, it requires that most of Trinidad outside of those groups need to be offered and accept the vaccine for us to get to that level.
And Madam Chair, may I just ask a final before I pause? Can I ask the PS or the CMO, as it relates to bilateral discussions with pharmaceutical companies, can we get an update, a status report as to where we are with Johnson & Johnson, where we are with Pfizer, as an example, and Moderna, as it relates to us ordering vaccine to meet that target that the CMO has just outlined? Can we get the status report on that?
Sure. Madam Chair, through you. So those discussions are at various stages. We are looking at in terms of the quantities that we are required. We are waiting feedback in terms of the availability of those supplies and also the commercial terms. So those discussions are still ongoing.
But have we?
Sorry.
No, what I'm trying to get, PS, can you indicate to this committee whether we as a country are looking at certain numbers as it relates to doses from Moderna, from Pfizer, and from Johnson & Johnson to satisfy the needs of our population?
Okay, so maybe let's see if I can explain. So in terms of specific numbers from the respective manufacturers, no, we don't have a specific number we're going to ask manufacturer A for, manufacturer B for, because it all depends on the availability. So we have an idea of how much vaccines we need, as you said, to achieve herd immunity. So what we're looking at would be what I call indicative orders, which would be how much we require as a country. And then based on those discussions with the various manufacturers, what they're able to supply, we then take those discussions further in terms of the commercial terms and the cost and delivery periods and what have you. So it's not that we're asking a manufacturer for a certain amount and breaking it up across, because we don't know what the supply looks like, the availability. So we're working with our overall figure for the country.
All right, thank you, Madam Chair.
Member Bacchus, would you like to join the discussion at this stage?
Yes, thank you, Madam Chair. A couple of things. I was interested, Member Mark alluded to it to a point, but I'm quite interested when you consider, and the CMO touched on it, that the minuscule, and I'm saying minuscule in terms of the amount of vaccinations that were given, 2.2 million versus 31 cases or 21 cases or 22 cases, of people that had specific things that may or may not necessarily have arrived out of what happened with the vaccination. How is Trinidad and Tobago, through its medical solutions, able to track people who will have received these vaccinations, whether for conditions that exist before they have them, before they have the vaccines, and whether or not things develop post them receiving the vaccine? Would someone elaborate on that?
So, Madam Chair, through you. So maybe I can just take that first, and if CMO needs to add, he can add to the answer. I would have mentioned during my opening remarks the development of an IT solution. So what an IT solution will do very briefly, persons who will be taking the vaccine, we'd register those persons with their biodata, all the other relevant information, and we track those persons. So that does, first of all, it lets us know who has taken the vaccine, type of vaccine, when they took the vaccine, and then if, heaven forbid, there are any adverse effects, that will also be recorded on that database. So that's one, how we will track persons who have received the vaccine, and two, in the unlikely event there are adverse events, we would have that information available also. I'm not sure if that answers the question or if there's anything further.
So basically what you're saying is at the point of admission where you receive the vaccination, they will collect information for you, store it in an IT solution. And based on should you have any type of reaction and you visit any medical facility anywhere, that there's reference to that and the fact that you would have received this vaccine, or this is, I just want to make sure I understand it. If you can track 22 out of 2.7 million, obviously we don't have those numbers, but localize things within any area in which the vaccine is being, that is something that we have to track from a medical perspective. I just want to make sure that if I walk into a medical facility today to receive the vaccine, I'm so authorized to do and I get it, that if I have anything that is happening within my body that we need to know about, one, will have to be disclosed. But two, should I develop any condition that happens subsequent to this and I walk into the Port of Spain General Hospital, for example, that there is a correlation between the fact that I would have had this and the fact that may or may not be tied to the fact that this vaccination is happening. That's the question. That's really where I was going.
Okay. Madam Chair, I'll let CMO take that, please. Thank you.
Yeah, so if I could walk you through what will happen. So you persons will come into the health facility. You will have your clinical assessment, which is your normal assessment. You will do a registration form, which will include, aside from your normal demographics, which are age and whatever else, what we normally do is we will capture whether you have a history of diabetes and hypertension. We'll take all that information and we'll have that on your file as well as on the registration form. We will follow you up after your vaccination in the health facility for 30 minutes in the first instance, which is actively monitored by the health staff. In the event that you get an allergic reaction, we will deal with it at that point. When you leave the facility, you will be, of course, given your card, so you'll know when you have it. So there's two forms of monitoring thereafter. There's active monitoring by the health staff at the county medical officer of health level through a telemedicine program which started with COVID-19. So those persons will be calling persons up periodically to find out if they do have any sort of reaction. So taking signs and symptoms, just like they do for monitoring quarantine patients. And we hope that that can be done for a protracted period of time, upwards to a year, to see if we have long-term side effects, those kinds of things. And we will also tell you and give you some sort of idea of what side effects to look out for and numbers that you can call in. So there's two things. There's the passive way where a patient can call in or come back to a health facility, and we will be actively following you up as well to determine if you have side effects to that particular vaccine. And we don't normally report to WHO any untoward events in the event that something does happen in our population, just like what we're seeing in Germany, for example. We will report that upwards through our IHR mechanism to WHO as well. So there's international reporting that occurs. If there's need for WHO to launch an independent investigation, that will be done as well.
Thank you, CMO. Let's shift gears a bit. Let's talk about security. I am concerned that there are a number of jurisdictions worldwide that have reported some cases missing things that I wouldn't want to say that it was stolen, but they're missing vials of vaccines. We received our vaccines last evening, well publicized. People know exactly where they are. They're held in the 40 facility here, some in Chagaramas. It's not well guarded by army and police from a transport perspective. But it raises the question about the security of the facilities in which our vaccines are being stored in one instance, the transport along the way of them getting to these multiple 21 distribution sites that we have, and the security of the said vaccines again when they get there. I recognize, of course, that distribution of vaccines is something that has been going on in Trinidad and Tobago for a period of time, but not necessarily this type of vaccine for this purpose that requires this level of security. How are we addressing, I would expect, the enhanced security requirements as it relates to storage, transport, and distribution at the areas for the point of vaccination in this?
Sure. Thank you. Through you, Madam Chair. So, as Member Bacchus mentioned, we've been doing vaccination for a while, so we have a well-established transportation system. Agreed, there are additional security concerns, which is why CMO mentioned at the start, we're starting with 21 health facilities. Those sites, we would have gone through an assessment process to determine which sites we start with. We have in excess of 90 sites, public health facilities in the country. We're not going with all of those. We started with those 21, they've met the various requirements, one of those being security at the site. So those sites have the appropriate security arrangements in place when vaccines are there. What we've done, we've also tried to implement as far as practical a just-in-time system within reason. So in other words, we will not be placing too many vaccines at these various vaccination sites more than necessary. So we'll place an initial supply. There'll be constant communication between our central storage facility and those sites in terms of what their usage looks like, when is their restocking level, and then we'll be sending vaccines out to those sites as needed. So there will be some buffer, but we don't want to put too much stock out there to minimize that risk. The other thing, in terms of the transportation, we are using our dedicated transportation for vaccines. So that is in place in terms of the proper cold chain arrangements and the security arrangements for those vaccines going out there. So in terms of storage at the sites, minimizing the volume out there, those sites have the appropriate security arrangements in place. We have the transportation in place, and as you mentioned, at the central level, we have additional security at the central level also. So we have sought to address the very real issue of security for those vaccines. Thank you.
Again, thank you for that answer. And lastly, before Chair and I allow other members, the 21 sites that were chosen, apart from obviously the storage facilities, the other concern that crops up with this, particularly, and again, we've been storing vaccines for a long time, some of which require specific holding conditions. How confident are you that these sites that have been chosen, including the holding sites, have all of the requisite resilience in its infrastructure support in terms of its power, in terms of its backup power, anything that is required to allow for the storage of these particular vaccines to be maintained, similar to the way we track them all the way from where they were. The CMO was quite clear in terms of looking at the temperature chart and so on, ensuring that was there. Now that they're here and they're stored within our facilities, things like power outages occurred, things like breaking down of refrigeration occurred, etc., not just at the holding sites, but also at the sites where they have to be stored, the 21 sites as you mentioned, and any others that you have. How confident are you, and what measures are there specifically to allow for the storage of these things that can be tracked to ensure that we have no breaches in terms of the integrity of the vaccine based on environmental conditions?
Thank you. Through you, Madam Chair. So let me start at the central level. There are backup power measures in place, your generators and what have you, at the central level. So there's that provision in place at that point. In terms of at the distribution sites, how confident are we that those sites have the necessary security and storage requirements? We're very comfortable because without getting into specific sites, there were some other sites that were looked at initially, but they had to be taken off that grid, and we replaced them because they would not have met our requirements in terms of being ready at this point in time to be used as a distribution site, as a vaccination site. So we had a team that would have personally visited each of those sites, looking at not just the security, other aspects, the physical environment, the equipment necessary, the HR, all the other things that are needed to ensure that this is a successful vaccination program. We looked at all those things. So to answer your question, we are very comfortable that they have in place the necessary arrangements to deal with loss of power. They have the security arrangements in place to maintain the integrity and security of those vaccines.
This includes, of course, the actual monitoring of the environmental condition in which it is being stored. So apart from an external thing happening like loss of power, you have them in a cooling units break down, things happen to them. You're monitoring even those aspects of it so as to ensure that, in other words, you leave it today, it's fine, you come back tomorrow morning and you realize you're warm. You have all of those things catered for in your storage and thing plans and monitoring plans for these vaccinations, yes?
Through you, Chair, short answer, yes. As I said, we do that for our normal vaccine. So we have just enhanced that and reinforced that needs to be done maybe a little bit more for these vaccines. But that is something we do in the course of business with regard to vaccines at our sites, yes.
Thank you, and thank you, Chair.
Okay, so Mr. Permanent Secretary, might I just ask you this? You spoke about the ICT solution. Was that in place when we did the first set, I think it's about the 1,128 vaccines or 1,108, of which the CEO, the CMO spoke of earlier? Was that solution in place, and was it used? And are you satisfied that it worked well? If there were kinks, that those kinks were sorted out?
Thank you, Madam Chair. So just to answer your questions, no, that system was not in place at that point in time when we did the initial 1,000-odd persons. We used an interim homegrown IT solution to capture the data for those persons who are vaccinated. What we're doing, we're going to be exporting that data from that solution into this solution. So it will become part and parcel of that solution. But at the point in time, it was not implemented at that point.
Okay, so that it's only with this current batch of vaccines that ICT solution will be used?
That's correct, yes.
Okay. And I also want to ask, Member BACCHUS asked about security, and there was an incident in 2019 where certain stores and so were stolen from the, I think it was the Northwest Regional Health Authority. And I want to ask from if there were lessons learned from that, and have there been remedial action taken from that incident that will ensure further security measures? You don't have to delineate them, because that in itself would impact on the security, to ensure that the loss or pilferage of vaccines internally would be minimized.
Oh, thank you, Madam Chair. So short answer, yes, we would have learned from that. Without getting into specifics, I could just briefly say that you'd have different components that you look at within there. One would be the whole issue of inventory management and inventory recording. That's where the IT solution comes in. You look at your SOPs, your protocols and procedures in place that need to be followed. And of course, critical with any of that is your monitoring and oversight. You have to have oversight. You have to look at your systems, review them, make sure that what you put in place is actually working. So from all those facets, we have put things in place that I believe would address that issue.
Okay. And your M&E unit, which will be charged with all of this oversight, is it adequately staffed?
So the M&E is, I wouldn't say it's a unit, it's more of a function within the organization. So in terms of how we plan to treat with the issue of M&E, I would maybe let Mr. Jai Singh, who is our lead in terms of M&E, speak a bit about that. Mr. Jai Singh.
Hi, Chair. Good afternoon. Yes, our M&E plan, we develop an M&E plan with all different stakeholders, including the RHAs and our internal team. We have about a 3-4 type tier model to monitor and track the operation of the vaccines, looking at the facility itself, looking at an assessment tool for the facility, looking at weekly reports from the operational side of it, looking at operational reports from a RHA perspective, and looking at the individual or the team from the ministry perspective to overlay and oversight that whole M&E function, which will report on a bi-weekly process to ensure that the vaccines are administered in the most proper, as PS indicated, with guidelines, protocols, with all the necessary tools for monitoring and evaluation in terms of the vaccine deployment plan.
So, Mr. Jai Singh, I have to apologize. With some of you all, we are having a difficulty in here, and I think it's in here because I see from how other members are following externally, you all may not have this difficulty. So, just in case I didn't get it, you had outlined in your plan specific objectives and milestones. Are those things in place? Like, for instance, the assessment tools, the reporting format, the reporting templates, those are all in place?
That's correct. The assessment tool, the reporting function, and also the M&E targets as well, which is critical for any vaccine deployment, such as coverage rate, uptake rate, wastage rate, unimmunized rate, and of course the adverse events rate as well. So there's a dashboard being in place with the IT solution to capture all the solution on real time. So in a given setting, for a week or a day, we will know exactly of the 21 sites, how much vaccines were administered, how much vaccines were used, and on a weekly basis, looking to see, on a daily basis, looking to see exactly what is the coverage rate for those centers and the population.
So who is charged with all of this data entry? Is it that this 21 data entry clerks who were budgeted for in your planned budget?
That's correct, yes. It is very, as PS indicated, it's very enhancing the vaccine deployment program with the additional 21 clerks who will be now in those facilities to capture data on real time. Yes.
So these were specially hired clerks and trained for this purpose?
That's quite correct, yes. To enhance the entire program.
So if I understand it, well, it'll be one clerk per distribution center to come up with the 21?
In this first phase, yes.
All right, so that one clerk will be working, what, 5 days a week, 6 days a week for the duration of the opening of the center?
there's also clerks, existing clerks at the sites already as well. So this
At
one
the center?
clerk,
At the centers?
at the centers, yes.
Yes.
So there'll be a minimum of two persons at the center. So in case anything happens, there's always one person there to capture the data as well.
Okay, so if I understand you well, these 21 add to what you already, to the 21 you already have, so it's 42.
That's correct.
All right, so the budget only caters for those special ones that you're bringing on to buttress your service.
That the additional staff, yes.
Okay, and while I have you, because I don't know if you or maybe the PS could help me with the budget. I see in the plan, there is a sort of summary, your estimated vaccine rollout costs. And for contracted services, which will be public awareness, print, public awareness radio, public awareness television, public awareness social media, and IT solution. In the summary, it is 2,925,000. And in the breakdown, there's a variance of about $605,000, which is $3,530,625. Am I reading it correctly?
Madam Chair, you are, and that is obviously an error. I do apologize. We didn't pick that up, but yeah, that is an error. So what is actually the 2 point in the summary? That's the error. What we're actually looking at would be the one under contracted services, where it breaks it out into print, radio, television, etc. That's the one we will be working with.
Okay. And therefore, is the total, I didn't go to the addition, is the total correct, or it changes by $605,000?
I will have to run those numbers for you, Madam Chair. I can't tell off the top of my head. Sorry.
Okay, so you let us know. Okay, member Dunarine, thank you very much.
Thank you, Madam Chair. Everyone is hearing me properly? Okay, good. CMO, I just want to direct a question to you. Perhaps you would have answered it already, but I just want you to run back the numbers for me. Now, you are saying that through the COVAX facility, we have already received 33,600 vaccines. From India, we are getting 40,000 vaccines, and we are guaranteed from China 100,000 vaccines. Is that correct?
Yeah, I believe that's the numbers that PS had indicated earlier. Yeah.
And in total, these 173,600 vaccines would be serving 86,800 persons, because 2 vaccines goes to 1 person, right?
Yes, all those vaccines that we get are 2-dose vaccines. Yes, that's correct.
Okay, so tell me something now. I saw in your submission that you all would have indicated that the COVAX facility is going to cover 33% of our population. When we remove children and pregnant women, how much more vaccines do we need outside of the 33% of the population that the COVAX facility is covering?
Okay, so if you do the subtraction, if you take out children and those pregnant women, breastfeeding mothers, you get down to roughly about 1 million people left. All right. So if you have 1 million people left, 33% is really actually covering the total of 33% of the total 1.4. So we're roughly left with about 37% to get to 70% of the entire population. All right. So that is, I think, taking us just above 500,000 persons. So it will be just over 500,000 persons additionally beyond the 33%.
Okay.
So somewhere between 500 and 600,000 persons.
Okay, so then tell me what timeline you are dealing with, because I know other countries have tentatively so for rich countries, for example, tentatively by mid-June, they expect to inoculate their vulnerable population. Some middle-income countries looking at middle of 2022 to inoculate their entire vulnerable population. What is our timeline looking at in terms of inoculating our vulnerable population?
Well, two different populations, right? So the vulnerable groups are really the persons who would be over 60 those with NCDs and those who are high exposure, for example, healthcare workers. So that's a different group. So we can't put a timeline on it unless we have a certain supply in terms of to give us that number. So we can't really put a timeline on it. What the two unknowns really are the delivery dates for the other vaccines beyond the one you spoke about, and the uptake by the citizens of Trinidad and Tobago. So really it is dependent on those two things, and I wouldn't want to put a timeline on it as yet until we know what those factors will be like.
Okay, so then now I know earlier on when one of the members asked about the amount of persons about 60 years old who suffer from non-communicable diseases, you were uncertain of the number. What is the method that you all are using to arrive, or what database are you all using to arrive at that figure of the amount of persons who suffer with NCDs above 60 years old who would be deemed considered vulnerable and be first in line to receive the vaccine?
So I don't know if any other member of the committee of the ministry has the actual number from social development, but I know we had written to social development to get the over 60s as a number. So we will take that number, of course, from social development to get an plus the number of persons. What we have done for the NCDs is we had looked at two sources. So we had looked at the sources of persons that are in the CDAP program and accessing CDAP, which we know to be somewhere between 180 to 200,000 with regards to certain disease that we are looking out to be vulnerable. So we add that to the number over 60, and then of course healthcare workers are somewhere between around 17,000. So we have a rough idea of how many people we're looking at as being very vulnerable in the population at this time.
Okay.
So, yeah.
Now, in this category of vulnerable people, now there are different NCDs. There's a broad range of NCDs in terms of severity. So like you would have some persons, for example, who are on hospital beds who would have suffered massive heart attacks, strokes, suffering with cancer, so on. How you all are ranking the vulnerable population? Is there further subcategorization in there, or is just once you have an NCD and over 60 years old and you come in this list, you qualify for the vaccine?
Yeah, so in the first instance, just for this 33,000 vaccines, which is the first phase, as we said, it would be healthcare workers and those over 60 with NCDs. We don't subcategorize it. Beyond that, it becomes extremely difficult logistically to do so. So we're using those broad categories to get persons in.
Okay, so therefore, if someone is hospitalized in one of the wards suffering from some sort of NCD, and is considered severe, they would not receive preference.
Well, there's two issues there. Clinically, it is not wise to actually vaccinate somebody during their acute illness. Actually, you have to recover from your acute illness before, especially if it is a febrile illness or an illness related to infection, before you can actually vaccinate them. So hence the reason we have not chosen patients who are in the hospital setting to vaccinate. We're choosing those who are stable and in the clinics as our first goal, because the ones who are in the hospital are usually acutely ill and they shouldn't be vaccinated at that point.
Okay, so as you mentioned, those persons who are in the clinics, right? Now, those are persons who are part of the public healthcare system. What about those persons who suffer with NCDs and do not seek public healthcare or are not part of the clinics?
Yeah, so if you're outside of the public healthcare system, you privately only, then you make an appointment. And in the coming days, we will, of course, put out our list. You can either walk in, you can call the relative health center, and you can make an appointment. Once you fall into that category of over 60 with an NCD, you will be given offered your vaccine at one of the 21 sites as well.
And what about, now, I know a lot of persons are expressing concerns about students, medical science students, especially those who are doing their internship on the wards and so on. Are they considered any part of this initial exercise, phase 1 of this exercise?
Well, because we only have 33,000 vaccines, they may be part of phase 1 going forward. But we haven't received any indication from the university in that regard or any queries. but we are going at our healthcare workers in the first instance. And we have considered the students in the clinical spaces as being at risk. And in the coming, later on in phase 1, of course, it will be considered once the vaccines become available.
Okay, Madam Chair, I would pause for now.
Thank you. Mr. CMO, maybe you could just give me some clarification, because is the category 60 and over with NCDs, or are there two categories, 60 and over and persons with NCDs? So I could be, not me, somebody could be 30 and having an NCD and be within that phase 1.
Okay, so let me just broaden it a little bit. So when we had described phase 1 over the last few months, we had said to the population that phase 1 will be healthcare workers, those with NCDs, and those over 60. Now, for this first tranche of vaccines that we received from COVAX, it is a small tranche, 33,600, relatively, compared to what we need to do all of phase 1. So we have decided for this particular 33,600 that it will be for healthcare workers and those persons over 60 years of age who also have an NCD, of course, putting them into a very high-risk category. Those in the public healthcare system who are borderline, for example, somebody is 59 or 58, the clinicians will have some degree of, they will be able to determine whether they are at very high risk of severe disease or death. And those people who are in the public systems will also be possibly offered based on clinical assessment.
Thank you. And therefore, to the PS and the Director of Communications, is there room for your communications to be adjusted somewhat based on the change that one has had to make for this 33,600? Because if I go to your website now, okay, and I look at, you have one that is done with slides, you're still dealing with phase 1, healthcare workers, 60 years and over, persons with NCDs. So is there room, and when I looked at your plan, it appeared that your plan catered for that sort of flexibility. When is your communication going to be adjusted to meet the reality?
Madam Chair, I will let Ms. Alcantara speak to that particular matter. Candace?
Thank you, PS, and through you, Chair, I hope everyone is hearing me well. Yes, okay. Thank you for that, Chair. Okay, great, thank you. So yes, you are right. We have left the information on the website as is because we are operating in phase 1. From tomorrow, you will begin to see very clear information which aligns to what CMO has said. And what we're going to be communicating to the public is that we are categorizing persons based on even highest risk and highest exposure. So we will indicate very clearly that with this tranche of vaccines, we are vaccinating healthcare workers and persons 60 years and over with NCDs. We will be doing this starting tomorrow with print ads, media release. We will use also all the free mechanisms possible. That means sharing to associations, that means sharing with other ministries, with RHAs. We will be doing a series of television, radio, and newspaper interviews to get the information out. And as we roll out as well, we will add paid newspaper, paid radio, and paid television. Today, we began the discussion in the conference on that. So tomorrow is our day for adjusting and making sure we have very clear information.
And what about your website?
Yes.
Charity begins at home.
Yes, so everything that we do goes on our website. So our releases go on our website, our ads go on our website, and they go on social media as well. That's a standard part of our rollout. Thank you.
So might I suggest you put something like revised or updated to help people like me with timelines? Okay, thank you, Member Webster Roy. Member Webster Roy?
Yes, thank you, Madam Chair. You all hear me now? Are you hearing me?
Perfectly.
Okay. I know the PS will indicate that there would be a just-in-time system for distribution of vaccines to the 21 distribution centers, and that we based on need going forward. What I wanted to know is what is the process for determining the initial number of vaccines that each of the 21 centers would receive now from this initial shipment? Also, how many vaccines from the first shipment would be sent to Tobago as well?
Thank you, Madam Chair. I will let Ms. Sibu speak to that. Ms. Sibu is in charge of the distribution of those vaccines. Anissa?
Thank you very much. PS, and through you, Madam Chair, are you all hearing?
Yes.
Perfectly.
Okay. Afternoon. All right. So with respect to the determination, we would have identified a figure of 500 doses for the initial distribution. Again, it would have been as a result of assessment in terms of what we would have assessed from the 21 sites, the persons going to the clinics. So it was a standard 500 doses that will be going out to each of the 21 sites. 1,500 doses will be going to Tobago, and that is expected to go to Tobago tomorrow. So 1,500 doses will be going to Tobago in the first instance. And for the rest of the 18 sites in Trinidad, it will be 500 doses will be distributed to each of those 18 sites in Trinidad. Thank you.
Okay, thank you very much for that information. So all centers, including the centers in Tobago, would commence their distribution on the 6th of April. With the Trinidad, each center having the initial 500, and in Tobago, 1,500 to go to be distributed equally around the 3 centers in Tobago.
Through you, Madam Chair, that's correct. We want all 21 sites to start on Tuesday, the 6th of April. That's correct. Yes.
Okay, great. Thanks a lot. Another question, and this is, we know when school reopens after the Easter break, I think our senior students, so those children who would be doing the SEA, as well as, those persons doing exam would be at school. From international reports and what we have seen locally, we know that children can become ill with the COVID-19 virus. Additionally, when school starts back for those senior children, we will have adults commuting, mixing with children in schools. What is the plan going forward for children? I know most of the vaccines now cater for above 18. However, we'll have a body of children moving around who will be under 18. What is the plan?
Okay, so as you know, there was a press release that was sent out from Ministry of Education indicating that both our ministries, Ministry of Health and Education, will meet next week to determine the way forward with regards to schools. What we have out for now, so what the Ministry of Health and Education has been doing is forms 4, 5, and 6 have been out to do practicals as well as SBA or any other such activity that could not be done virtually, which was last term. It has gone pretty well so far with only one positive case from that setting in Tobago, if I remember right. We have to have discussions centered around, based on our numbers that we have seen over the last 2 weeks. There has been a significant increase in the number of cases. Our rolling average has gone for hovering around 3 to 4 for a month or more to 17 cases for a 7-day average within the space of 2 weeks. We're going into a period of Easter, and coming out of it, we expect to see, we have to wait and see what the numbers will be like. And of course, when we meet with them next week, we'll be in a position they will be in a position to better indicate that's Ministry of Education as to what happened thereafter. But we have to wait and see what the numbers look like post-Easter. We will meet with Education, and then they will ultimately be responsible for saying what happens then. By way of keeping the children safe outside of vaccines, they have to continue following the public health guidelines, and not only the children, all of us, to ensure that the children stay safe. The vaccination of the adult population is meant to create some sort of herd around the vulnerable populations that cannot be vaccinated, including children. So continuing all the public health measures is what we can do as a population. And of course, the ones that can be vaccinated, we need to get the vaccine when it's available so that we protect the vulnerable ones that can't do so on their own.
Thank you, Madam Chair.
That all? Member Webster-Roy? Yes? Then therefore, can I call on Member Morris Julian?
Thank you, Madam Chair. Madam Chair, through you, my question is directed to Ms. Alcantara and perhaps the PS with regards to the communications plan for the misinformation that will be fed to the public. We are well aware there are segments of the public that will try to push people not to get vaccinated, use all sorts of Facebook news, I like to call it, to justify not using the vaccine. Is there a plan to deal with this? Because the misinformation is very real, and it's quite scary to me to think that normally reasonable thinking folks might quicker get their information off of a Facebook post than actually rely on the Ministry of Health website like I do to ensure. Is there a plan? Is there a set plan to deal with something of this nature?
Madam Chair, I'll let Candice answer that. Candice?
Thank you, PS, through you, Chair. Thank you very much for that question. It's something that we have been addressing since the beginning of the pandemic. What we try to do is to respond as quickly as possible and via at least the same communication channels that we use to send the information out. So for example, if something is sent on WhatsApp, we try to make sure that WhatsApp is one of the mechanisms we use to push the information. Moving forward, part of what we communicate will address some of the misinformation. For example, accurate information about the safety and side effects and the efficacy. Those are very important points of communication for us. And you will see that in all that we communicate. What we have done, we have continued to have not just Ministry of Health subject matter experts on our media conference, but other persons, for example, from the University of the West Indies. We partner with the University of the West Indies to do a conference for healthcare workers, and we will be doing one with University of the West Indies for the public. It will be virtual and aired live on television. We are also reaching out to the RHAs to get testimonials for our healthcare workers who have received the vaccine. Studies both for Trinidad and Tobago and internationally indicate that healthcare workers are some of the most trusted persons when it comes to persons and their healthcare. So we did a lot of internal work with our healthcare workers so that even if people are getting misinformation on one end, when they interact with their healthcare workers, they get the accurate information and it's a trusted source. Those are just some of the mechanisms. But of course, as I said, in all our communication, we will include facts about safety and efficacy. I hope that answers.
Yes, thank you. And I agree. You all have been doing an excellent job with communications throughout this whole pandemic. I would also like to just make a suggestion that we also focus on the young people. They may not be able to take the vaccine as yet, but they tend to take the message across to their parents and their grandparents, and they'll be able to make sure that the actual facts are out there. Because I can tell you, my 13-year-old warned me about COVID-19 long before I thought it was a reality. And I told him not. But when we reached on that, clearly I was very wrong.
Thank you. I'll take note.
Okay, so that while I have your ear, Ms. Alcantara, in the plan, the deployment plan, I guess we will be in phase 1 of vaccination deployment. And I know you said that from tomorrow things will start up. You had a public sensitization activity virtual town hall meetings, which are public. Is that still going to be carded for the second week of April?
Thank you, Chair, for that question. Actually, we adjusted the date back based on the confirmed arrival of the vaccines. So it should be the week after that. I'm just confirming with University of the West Indies and TTT, who's going to stream for us live to the other television stations. So the date we're actually looking at now is the 15th of April, all things being considered.
Oh, so that virtual town hall is the meeting with UE.
Yes.
Could you then, well, because I'd expect by now, the plan, that communication plan has been now populated with dates. Okay, your launch of the main campaign, vaccine campaign, your engagement of an external firm, your M&E and so on. Would you have that, could you make that available to the committee right up to your follow-up media engagement?
Okay, that's what Chair will do.
Yes, if you can make that available to us in writing.
No problem, noted.
Thank you very much. Might I now invite, thank you. Might I now invite Member Barthelemy? Thank you for waiting.
Good afternoon, everyone. Thank you, Madam Chair. So my question is along the lines of communication. So further to what Member Morris Julian mentioned about the fake news that we will be experiencing, you would have spoken about the different types of content that you plan on putting out to make sure that the public is well informed and to make sure that they trust the vaccination process and all of that. But have you considered possibly developing an app, a mobile app that can provide constant updates on the vaccination as well as any and all communication coming out of the Ministry of Health? The reason why I'm asking is because, yes, we can use social media, we can use all of these different things, but we have seen that during this, this pandemic, mischievous persons have used the ministry's letterhead to push fake news. So could this be a possibility where persons can just download an application and they will constantly be updated on what is happening as far as vaccinations is concerned and any kind of information coming out of the Ministry of Health? Yeah.
PS, you want me to go ahead and take that?
Yes, Candice, thank you.
Okay, thank you very much for the question. Through you, Chair, yes, that is in the plan. The IT system will integrate back end and front end. And one part of the front end is an application that we can use to push information and not just pull information on side effects and that type of thing. So yes, that is the plan.
And just a bit of consideration to put into the application, if you can also cater to persons who may be vision impaired as well as hearing impaired. So everyone will be able to use the application.
Noted, thank you.
Member Bodo, might I invite you now, please? Thank you for waiting.
Thank you, Madam Chair. Madam Chair, if I can just engage Ms. Alcantara with a follow-up question. It was mentioned that doctors and so on will be utilized to encourage and to assist the public. Is there any plan to engage public figures, for example, entertainers, leaders in the society and so on, to assist and encouraging the population to take the vaccination? I directed this to the communications person, Ms. Alcantara.
Okay. Thank you very much for the question. Through you, Chair, yes, that is part of the planned celebrity endorsements. What we're doing, though, is based on the research. We have such a high rating for healthcare workers. We put emphasis on them first, but the intention, yes, is to include public figures, sports persons, and celebrities in our messaging. Thank you.
Thank you. The reason I asked this as well, and you did mention the workshop that was held with the Ministry of Health in conjunction with the UWI, and I was present to that workshop. And in fact, there was a paper presented based on a survey that suggested that only 27% of the population was willing to take the vaccine. So in addition to the fake news, we have the issue of what is called vaccine hesitancy Can you tell us whether there has
Chair, I'm not sure if it's just me, but Dr.
been any
Bolos.
further
Oh,
sorry, I was saying, Ms. Alcantara, can you state whether there's been any further research in that area internally by the ministry to get an update as to what the extent of the problem could be?
Thank you very much for the question. Through you, Chair, the University of the West Indies formed a vaccine hesitancy or / vaccine acceptance committee, and we are due to receive a report from them soon. They have done some research in Trinidad and Tobago as well, and they continue to do work apart from the presentation that was made. So I should receive that very soon, and we will look at the numbers then, but I don't expect a big change at this time. The numbers kind of align to what we're seeing internationally at this point.
Thank you. Madam Chair, if I can, to the PS. PS, we had gone through the various procurement methods and so on, and we've come up with a figure of 240,000. But initially, the ministry and the minister had indicated that the African Medical Supplies Platform would have been engaged to try and procure some additional vaccines. Yes, can you give us an update on the status of those negotiations?
Thank you. Through you, Chair. So those negotiations are ongoing. Remember, we have indicated to the platform what are our requirements, and we are waiting the commercial documents to enter into a firm contract, at which point we'll then have confirmation of the confirmed quantities and hopefully the delivery dates. So that process is ongoing.
So would it be correct to say that we can still expect some vaccines through that platform?
That's our expectation, yes.
Thank you. Yes, now you mentioned the 21 centers, 3 in Tobago, 18 in Trinidad, and I know you would have gone through a process to identify these centers as being appropriate and adequate and so on. I looked at these centers in terms of the geographical location and the ability of citizens to access some of these centers. There is a gap between the Siparia District Health Facility and Point Fortin. And for those who are familiar with the area, it's a long stretch of road, and there is a Palaseco Health Center. So I'm wondering whether you might want to give consideration going forward to including that particular health center. Because residents from that area will may find it difficult to get to Point Fortin on one end or Siparia on the other end, and we really want to make life easy, for people wanting to access the vaccine. Would you care to comment on that?
So, through you, Chair, member, definitely we can look at additional sites. As I did mention, these 21 sites are what we're going to be starting with, and once we have adequate supply of vaccines, we will seek to increase the number of sites. So definitely that we can look at that.
Thank you. If I may, through UPS, just the CMO, and just to ask, now we have been spending a lot of state funds and so on, and in terms of the quarantine requirements for citizens returning to the country. So my question is the ministry giving consideration to reviewing and perhaps revisiting the quarantine policy for returning citizens who would have received the vaccine? I don't know whether the CMO would be in a position to say something on this.
Yeah, so the quarantine process is always under review. It's constantly under review, looking at the new data that comes to us from time to time. And the issue of, having a vaccine and returning safely to your country has been raised for a few months well now. The only vaccine that has proven to decrease the transmissibility of COVID-19 definitively by doing nasopharyngeal swabs after you have been vaccinated is AstraZeneca, which shows a 67% reduction in the actual virus being present in your nasopharynx and, of course, being able to transmit from one person to the next. Notwithstanding, the policy remains the same for now, meaning that anyone who comes in, whether you have a vaccine or not, will be required to do 7 days state quarantine followed by 7 days home quarantine. There's an ongoing study with Pfizer as well, which is looking at the same sort of endpoint to see if there's protection by way of transmissibility. And I'm not aware that the other vaccine manufacturers have gone that far in terms of looking at that aspect of it. A lot of focus has been on decreasing the severity of disease, decreasing the risk of death for those populations that are vulnerable. So going further down the line, there may be room for amendment of the quarantine policy, but not at this point. At this point, we hold our policy as it was before and continue with regards to repatriation as it was related to the policy.
Thank you, CMO. Now, I know the global conversation has been the shortage of vaccines, but as you're aware, many of the developed countries would have ordered more vaccines than they require. And, you know, I'm an optimist, and I'm hoping that perhaps in the near future, you know, we could be in a better position in terms of being able to receive more vaccines. My question is that, is there preparation in that event for what is termed mass vaccination campaigns? Are you prepared? Are you in the planning phase of looking at that possibility, just in case, you know, that situation does arise?
So we have looked and said in the public domain that we are exploring the option of having mass vaccination sites. Initially, we were looking at 4 to 5 sites spread across the country geographically to enable persons to come in and exit the site very quickly and have large proportions of persons vaccinated in a short period of time. So those plans are well on the way. Of course, we will finalize those plans based on the availability of the vaccines in large quantities, and then roll it out thereafter eventually when we do get that supply coming in.
Can you share with us where those sites might be?
So just roughly what we envisioned is a site in North, South, Central Trinidad, one in possibly East, and then one in Tobago. We haven't confirmed those sites as yet, but we will in the near future.
Thank you, CMO. Now, in terms of going forward and trying to determine the immunization and the immunity status of the population, now that we are rolling out vaccines, is there any intention by the ministry and or the university to look at any ongoing studies in terms of antibody testing, both from a scientific point to determine how long the immunity lasts from these vaccines, and also to give us some information with regards to immunity in the population following vaccination? Are there any such plans?
Yeah, so I did have preliminary discussions already with the University of the West Indies to see if they can utilize antibody testing in a structured way for academic research to look at just that. So we're looking at one, population immunity prior to vaccination in certain groups, following up persons maybe who have been positive as an option of research to see how long their immunity lasts. And of course, post-vaccination, what happens to your antibodies, bearing in mind that the antibody tests that we do really tell you or stay positive for about a month after either an acute event or usually after a vaccination event. So we have to bear those things in mind, but discussions have started. We want to firm up in terms of research, and we go through the normal process of ethical approval because it is an invasive test that we'll be doing. But we'll ask that possibly you will lead that endeavor with partnership from the Ministry of Health.
So I just want to close with one final question. Now, you mentioned the figure of 17,000 healthcare workers. I just want to clarify, are you just saying that that's the number identified for this first phase, or does this reflect the total number of healthcare workers in the country? The reason I ask, and I also want to inquire, whether these will include, for example, attendants, clerical staff in the wards and the A&E and so on, the clinical spaces, and those who work in the health centers and so on. Is that the number? Or is it the number identified?
This is the total number of staff that we have gotten. It doesn't speak to physicians alone or nurses alone. It speaks to all healthcare workers.
Within Trinidad and Tobago?
Yes.
All right. I just raised that issue because I know SWRHA, for example, has about 4,500 employees. So I'm just a little concerned, but I'm presuming that these figures have been checked.
Southwest, as you know, has about 40% of the catchment of the country.
Yeah. Okay, Madam Chair, I'll hold for now. Thank you.
Thank you very much. Member Mark, unfortunately, I'll ask you just to wait your turn because I didn't see a hand up, but I'll put you down on the list. I now call Member Dionarine.
Thank you, Madam Chair. CMO, could you, how persons who would have already been infected with the COVID-19 virus, are they eventually going to be considered during any of the phases of the vaccines to be vaccinated? Or is it that we are understanding them to have developed sufficient antibodies and they are more or less last on the list, as is in countries such as the US?
So someone that has been confirmed as having COVID-19 in Trinidad and Tobago, the policy is for now that they will be offered after a period of 6 months post your positive test. Bearing in mind that that is WHO's recommendation as well in terms of the waning of your naturally acquired immunity. What we know so far in the research is that we wait a period of 6 months to ensure, of course, that long COVID, in the event those persons may have a long COVID episode, that passes, so that 6 months you can safely be re-immunized as a sort of booster in a way to COVID-19. So we wait 6 months and then we can offer it at that point in time.
Okay, and what I saw mention made several times in your submission about the daily wastage. And isn't that is understood that daily wastage is expected? I'm just asking because of how limited I know the vaccines are. And if it is expected, how much is usually expected on average?
With this vaccine, we set a very high threshold really to expect no wastage at all. And as I described before, there's a good feature that we found that when you have a vial of 10, you're actually getting 12 out of it. So in the first bit, as I said, we got enough to give 2,000 doses, but we were actually able to give 1,128 from the first 100 vials, which is more than we expected. So we actually may not even have wastage in the truest sense of it, but we're looking towards a target of 100% with little or no wastage for this vaccine in particular. Okay.
On page 43 of the submission, when you all spoke about ultra low freezers, mention was made that, and I quote, there will be a need for equipment to facilitate the transfer of vaccine supplies with the requisite cold chain support between the central hub and satellite locations. Is it that you all don't already have these freezers, or some of them still have to be bought?
Okay, so let me speak to the clinical part of it first, and then I don't know if someone else can take up the actual acquisition of the freezers. So the clinical aspects of it, and just for the population to be assured, all of these vaccines, whether you deal with a -20 vaccine, a -70 vaccine, or a 2 to 8 degrees Celsius vaccine, once they come off of central storage, they need to go to 2 to 8. So all our systems in the periphery will remain the same as they are now. What is different is that they require, at the central level, storage at different temperatures. For example, AstraZeneca will need to be stored at 2 to 8 at a central level, as well as through delivery. Pfizer will need to go to -70. It goes down to 2 to 8 and can be used at that temperature for about 5 days. Moderna at -20. And once they come out of that system, they can be used at 2 to 8 for about 30 days. So all of them on the periphery will be 2 to 8. The only need for the ultra lows are the central location when they're storing for long periods of time. So I don't know if anyone else wants to jump in with the actual quantities of the refrigerators we have.
If I may, Chair, just to add, so those freezers listed on the plan would have been additional freezers we were seeking to purchase for COVID-19. We do have capacity within the country already for both the -20 and the -80 degrees. So there is capacity within the country. As I said, those were just to supplement our existing capacity. Thank you.
Okay, PS, as I have you, I don't know if you would be able to tell us also, mention was made through the, that you're trying for persons outside of the public healthcare services, you're trying for them to make appointments to get the vaccine, right? is consideration being given to include this on the ICT platform so that persons can make these appointments online? And the second question is, I'm asking this primarily because, you know, we want to prevent persons from, a whole set of persons from flocking into the health centers and all the various vaccination centers to get the vaccine. So what is being put in place to prevent that from happening?
Sure, thank you. Through you, Chair. So to answer your first question, yes, the IT system would have the functionality ultimately to take online appointments. That's not going to be launched at the start, but it is planned to be part of the IT solution shortly. In terms of preventing that rush or persons all congregating at the health centers, what will happen is that each RHA will have dedicated numbers where persons can call to make an appointment. So each RHA will manage their facilities. So in other words, if you call, they will book for their particular health center, and that will hold for the other RHAs. That's the solution we're using right now, but the IT solution would allow for it.
And I know I don't mean no offense by asking this question, but in local, you know how things happen in Trinidad. So, I mean, what is in place to prevent persons from skipping the line? Oh, I have a friend in Ministry of Health or in some various public entity, and I'm going to try to get the vaccine, call them up. What is being put in place to prevent something like that from happening? This is a question from the public.
Sure. So let me just say that whether you use an IT solution or you use a manual solution, as they say, you're going to have that very real concern. And that's why we let the RHAs at for their respective sites manage the appointment system, and they will book persons based on priority and availability of the vaccines.
Okay. I just want to move on to the budget for a couple questions, Madam Chair, if you allow. And it is with respect to, I saw mention was made that the Inter-American Development Bank is partially funding this, the vaccination rollout cost. Could you identify what amount and percentage of the total cost that the IDB is assisting with, and also the amount that the balance that the government is financing?
Sure. So through you, Chair, member, I can give some details. I don't have the specifics, which we can send you in writing if you wish, but in terms of what elements they're covering, so they would have met the cost of the initial batch of COVAX vaccines that we got yesterday. They're paying for that initial batch. They're paying for the other batch that's due to come in by May. So they're paying for those vaccines, the first shipment from COVAX. They're also funding the data entry clerks and the nurses that is covered in our plan. And they're also paying for some element of the communication plan. All right. So those are the elements. In terms of the actual dollar figures, I don't have that with me, but we can submit that to you in writing if required.
Okay, and submit the percentage between IDB and government financing as well. And sure. If the government financing is primarily from the consolidated fund or if it's funding from elsewhere.
Sure. Yes.
Yeah. Thank you, Chair.
Can I now call Member Mark?
Yes, thank you, Madam Chair. Madam Chair, may I just follow up on what Mrs. Senator Diona Ryan posed a short while ago by asking the PS if he can make available to this committee in writing contributions, grants, and loans by all international agencies, lending, international financial agencies towards assisting the government and the people of TNT as it relates to this COVID-19 pandemic, whether it's the World Bank, the IMF, the IADB, CAF, or any other donation coming from any other agency. They can put that in writing for us, Madam Chair.
Through you, Madam Chair, we will do that.
Yeah. The other thing I'd like to ask the PS is, or the CMO, has to do with donations. What is the status of further donations of COVID-19 vaccines, inclusive of the COVAX facility. And let me just elaborate. I know that the Indian government and people have offered 40,000 AstraZeneca. Can you give us a timeline as far as you are aware as to when those 40,000 may arrive? And the President of the United States, President Biden, has provided Mexico and Canada with donations of vaccines. And I know that our Prime Minister, who is chairman of CARICOM, has written to the President of the United States seeking assistance through donations. Can you give us a status report on these two matters, please?
Thank you. Through you, Madam Chair, with regard to the 40,000 doses from the Indian government, we're currently in discussions with the embassy, the Indian High Commission, and they have to give us a firm date for delivery. So we are waiting a date, but we are working with the Indian High Commission to get a date for those doses. With regard to the other matter, is being dealt with through the Ministry of Foreign Affairs. I don't have specifics into the status, but again, I can liaise with Ministry of Foreign Affairs and Foreign and CARICOM Affairs and provide feedback.
Yeah, okay. Can you be a little more specific? When I asked earlier, and I thought you were a bit vague and not certain, what is the real status of negotiations between the government represented by the Ministry of Health and private sector organizations desirous of accessing and supplying vaccines to the Republic of TNT, either for their workers or to have them sold to the public over the counter? Can you be a little more specific and tell us where we are with those negotiations, those discussions as it relates to the private sector? Because they are very anxious to get involved so that they can get their workers vaccinated quickly and get their businesses operating more fully. So could you be a little more specific, Mr. Pierce, and tell us what is the status of those discussions?
Sure. Through you, Chair. So for those agencies that would have approached the ministry, we would have responded, asking them certain questions, clarification to the specifics, source of the vaccine, storage conditions, etc. Once we get a response from them, we will then look at those and then take it from there. So in terms of where we are right now, we would have written to responded to those requests that we got, and we're still, as far as I'm aware, we are still waiting feedback from those agencies.
Would these private sector organizations be given a license to import directly from source, or would they have to come through, or would these vaccines have to come through government and then deployed to the private sector? Can you clarify?
All right, so I'll let CMO clarify with regard to the whole issue of the regulation of vaccines and the importation of vaccines.
Yep, thanks, PS. So with regards to regulation, any vaccine or drug that needs to come into the medicine that needs to come into the country has to be registered with the Chemistry, Food and Drug Division. If the vaccines that would be registered already, for example, AstraZeneca vaccines out of those manufacturing sites, they are already registered, meaning that someone who wishes to purchase from those registered sites can do so and bring it into the country. They would need to still alert Food and Drug Division of the supply, and there's a single electronic windows solution that is used by the customs as well as Food and Drug to alert us that a vaccine is coming into the country. So by way of regulation, if it is a new vaccine that has not been approved in the country for use, then the person that is bringing it in or their agent will apply to Food and Drug for a new drug license to import that vaccine into Trinidad and Tobago, and then they can bring it in once they get that import permit.
CMO, are you satisfied that we have the relevant, robust infrastructure and the necessary testing and lab facilities to ensure that any counterfeit vaccine that are imported from abroad, whether it's from the private sector or otherwise, would be subject to rigorous testing so that the population is not exposed to unnecessary vulnerabilities?
Yeah, so the pharmacovigilance arm of it, usually what happens is that there's a collaborative effort between the Caribbean CARFA as well as PAHO and possibly the principal manufacturers of the vaccine. For example, if someone tries to bring in a fake version of AstraZeneca, what happens is that we can send that to CARFA, to the Jamaican lab. Kariri can do some testing in that regard, or we can alert PAHO and the principals, and they can actually test the sample from a pharmacovigilance perspective to ensure that the testing is done, and we can tell if that vaccine is authentic or not from that arm of it. What needs to happen is, I think the public needs to be made a little bit more aware as to what signs to look out for. We did have a session in the press conference, and we sent out a press release indicating what are the indicative signs of a fake vaccine or a fake medical product. For example, the labels and those kinds of things. But I think that there's always need to update the public a little more as to what to look out for. But as I said before, for now, vaccines will only be given out for COVID-19 in the public system. And that gives us some level of assurance that, the population will know once you come to the public system that you'll be getting an authentic WHO approved vaccine.
And CMO, as I have you on the floor, may I also ask whether you can give us a breakdown briefly and then maybe put it in writing as to the cost per unit, per dose of each of the vaccines manufactured by the various pharmaceutical bodies, whether it has to do with the Serum Institute of India, AstraZeneca, Pfizer, Moderna, I think is the name, and also Johnson & Johnson. Do you have a breakdown per unit cost per dose?
Member Mark, if I may intervene, I will not allow that based on how the conversation has been going thus far. Because very early, I think Mr. Ali would have told us that based on negotiations and constituent documents, then price will come into play. Okay, and that was again in response to a question you had asked about Johnson & Johnson, Moderna, and so on. So that I think that is the question being asked in another way. And I think having regard to what has been said already in the conversation, that has been asked, answered, and is just not available as yet. Important, yes, but I think it's a bit premature having regard to where they are in the negotiations with people, individual companies like Johnson & Johnson, Moderna, etc. Okay, so if you have another question, I'll allow that, please.
I have many more, Madam President.
Well, you know how we do it. We are very democratic here.
Yeah, well, I'm a Democrat myself. Yes, may I ask through you, Madam Chair, what measures will be implemented to ensure accountability and transparency throughout the disbursement of vaccines in Trinidad and Tobago?
So I guess that's for Mr. Ali.
Yeah, either one, Mr. Ali or the same.
Sure. Thank you, through you, Madam Chair. So in terms of the whole disbursement distribution of vaccines, we spoke about it briefly during the conversation in terms of that whole supply chain, what measures we have in place, the IT system, and critical to all of that would have been the M&E, the monitoring and evaluation, the audit, the oversight. So even in terms of having the protocols in place, having those parameters in terms of the various target groups who would be eligible for vaccines, once we start the vaccination process, there would be that audit taking place in terms of ensuring that persons who are vaccinated are in fact persons who meet the clinical criteria, the WHO criteria that we have put in place. So that is part and parcel of our audit function.
Yeah, may I also ask through the chair to Mr. Ali, despite the Ministry of Health's responsibility for the oversight of vaccines, which entity will be responsible for the direct deployment of the vaccine as to ensure accountability?
Sure. Thank you, Madam Chair. So, as I indicated earlier, that falls, Ms. Anissa Dunat Sibu, our principal pharmacist, would be the point person to manage the distribution of vaccines based on usage and the requests from the various vaccination sites. All right, so there's a system in place. We're building on our existing vaccination program and that logistic framework that we have in place to manage the usage, request, and disbursement of vaccines from the central site to the respective 21 vaccination facilities.
If I could, just 1 minute, Member Mark. Just let me ask you one thing, following up on that. So, Mr. Pierce, can I ask if the buck stops with the vaccine task force?
Yes, Madam Chair, that's correct.
Yes, Madam Chair, my final question to Mr. Ali, well, I think Mr. Ali might be the better person. In terms of your national vaccination deployment plan, I noted in the appendix something known as the National COVID-19 Steering Committee, made up of 16 members. But I just wanted to ask whether this body, I don't know who appointed this body, but can you tell us, Mr. Pierce, whether there's an intention of ensuring that the private sector is represented there, the trade union movement is represented there, the civil society organizations are represented there, as well as the interreligious organizations. And the reason for this is that as we seek to deploy and we seek to get delivery of vaccines, and with all the news that is competing for the minds and hearts of the people, it is critically important that the National Steering Committee is made up of bodies and forces that represent large segments of the national community. So I just wanted to know through the chairman whether consideration is being given to the involvement of the private sector, the trade union movement, civil society organizations, and the interreligious organization.
And just for uniformity of language, is there a steering committee or a task force, or are there two different things? So you could address that to Mr. Ali when you're answering Member Mark's question.
Sure, thank you, Madam Chair. So with regard to the task force, which is what I'm referring to, that COVID-19 vaccine task force was really an internal management structure that we put in place to really treat to the issue of the supply chain for the vaccine, in terms of from procurement, in terms of receipt, the entire supply chain to vaccine administration. In terms of the involvement of other stakeholders and external stakeholders, it is something that we will definitely take on board, that suggestion and that recommendation. But in terms of its original intent, it is really to manage the supply chain for the vaccines within the public health sector.
Thank you very much, Madam Chair.
So it's still, Mr. Pierce, to make it clear, there's no steering committee, it's a task force. I just wanted to be clear for the conversation that they're not two different bodies, but there's one. Yes?
Yes, that's correct.
Okay. All right. So,
Madam Chair, is Mr. Ali saying that we have what? Do we have a national COVID-19 steering committee, which is outlined in Appendix 1 of the document?
Well, if I hear it well, there is Appendix A, which is the terms of reference for the COVID-19 vaccine task force. So I don't know if we have two different documents. And I think from what I understand, Mr. Ali said, he said there's a task force. I think his answer on that there's no steering committee answers itself. Okay, so there is a task force.
Thank
okay?
you.
And that's what he's described. All right, Member Basalami.
Thank you, Madam Chair. I just have a follow-up question from a question I would have asked earlier to Mrs. Alcantara. We spoke about the app being in development. How soon can we expect this? Because as we see, everything is happening very fast.
Thank you very much for the question. Through you here, I think PS, would you be able to give us a little indication of the time frame?
Sorry, Madam Chair. Sorry, could you just read that? Something went wrong with my computer there. I don't know what happened. I'm sorry.
Oh, would you like me to?
I think they'd like you to re-ask the question, Member Basalami.
Please, Taffy, I'm sorry.
Following up, no, it's okay. Following up to my question earlier about an application to provide updates, how soon can we expect this application to be available to the public?
Thank you, Member. Through you, Madam Chair, I will have to liaise with my IT department. I'm hoping within a month, but I don't want to commit. I need to get that feedback from my IT department and get back to you, to the committee.
Okay, no problem.
Member Basalami, are you through?
Yes, thank you, Madam Chair.
Okay, Member Bodo.
Thank you, Madam Chair. Just one last follow-up question to the CMO. CMO, I know that you would be very concerned and you want to assure that the most vulnerable receive these first vaccines. And I know that you have the database from the public health centers and the hospital clinics and CDAP and so on. But as you would know, that there are many high-risk and vulnerable patients who will be seeing their private practitioners, general practitioners, and so on. Is there going to be any role for these GPs, for example, who see quite a number of patients and assist the public health sector? Is there going to be any role for them, for example, to provide a listing to the ministry in terms of suggesting patients who will benefit at this time?
For now, in this particular phase, what we are hoping is that people from those vulnerable groups make appointments at the various institutions, just because we have only received 33,000 vaccines to date. As we get more and more vaccines, definitely there will be a greater role for the sentinel physicians, even the private sector to some extent, possibly, and the sites that we described before, mass vaccination sites. But for now, we are trying to restrict it to the 21 sites and work by way of appointments for those who are outside of the system.
So the advice to GPs would be to identify their patients and encourage them to go about.
Yes, of course, to identify the patients, especially the most vulnerable ones, and encourage them to make their appointments and seek vaccination as early as they possibly can.
Yeah. So, CMO, in terms of homes and so on that would have vulnerable elderly people, any of those homes going to be targeted during this initial rollout?
So again, we look at the same sort of advice because we really want to keep it at the centers for two reasons, for clinical reasons as well, because it is a vaccine that is being given at those centers and it will be delivered in a way that it can be clinically monitored. So when we did the assessment that PS spoke of, there was a robust clinical arm of it where we actually ensured that the crash carts in those health centers were properly stocked, and we actually went a step further to ensure that all the physicians in those facilities who would be working there were ATLS trained in the event that something were to happen and have ambulances on standby. So we want to maintain it in that system for now, for safety. We will, of course, ask persons relatives of those individuals to bring them in, make appointments as the private sector NCD clients for this, at least for this first 33,000, and then we will advise as we get subsequent tranches into the country.
Madam Chair, thank you. I just want to close by CMO wishing you all the best. I know it's going to be an unusual time, a very unique event on Tuesday, the 6th of April, and to wish you and the ministry all the best and to pledge my support, as required going forward. Thank you. Good luck.
Member Deodarine, your hand was up. Is it now down? Yes. Member Dionorine. Member Dionorine, are you hearing?
Yes, I'm hearing.
Yes.
I'm on mute. Apologies. Mr. CMO, based on an earlier response, you would have said that persons with certain chronic illnesses who are deemed severe, it will depend on their level of severity if they can be administered the vaccine. So how about in instances where persons suffer from severe lung diseases, for example, COPD, and so on? Would they be in a position to be administered the vaccine, or would they be considered one of those persons who would not be qualified to receive the vaccine?
Right. So chronic obstructive pulmonary disease is a broad category of diseases that include things like that we commonly know, emphysema, asthma, and those like diseases. But again, they do put you at they make you very vulnerable to a respiratory disease like COVID or influenza. So we would ask that those people actually fall within the vulnerable groups and fall within the entity groups that we want to target. Of course, if you are in acute on chronic phase, meaning that you have an acute exacerbation of the illness, you would not be able to get the vaccine at that point in time generally. But once you're in that chronic stage, then we would advise that those people be given priority in terms of the vaccination program.
Okay, thank you. And thanks to the entire Ministry of Health team for their excellent work thus far since this COVID-19 pandemic. Thank you, Madam Chair.
Member BACCHUS.
Thank you, Madam Chair. This just came to mind. So everything works in a chain. So the idea, we have a certain amount of storage, we have a certain amount of distribution, we have a certain amount of sites, and therefore we can vaccinate a certain number of people. What is the expected? So I know we're going to do, as projected, 1,000 more or less by this time. We have a projected end date to utilize all of these vaccines that we have. But thinking forward and looking expansively, what really is the projected nominal rate that we can really vaccinate people in Trinidad and Tobago? And I say that from the point of view that it probably doesn't make sense to get 1 million vaccines next week, because we probably can't store them, we won't be able to distribute them, we won't be able to get them in arms, and then they have finite periods of shelf life. How that marriage, that harmony and symphony of how this works, what really is the projected roll rate for distribution and for vaccination of people in Trinidad, all things being equal?
Thank you, Madam Chair. So I'm not sure if CMO would want to add to that, but let me just say that is dependent upon, well, two factors. One, we didn't mention the public health facilities, but CMO also mentioned earlier, we're looking at mass vaccination sites. So obviously the mass vaccination site, you might do more than one vaccination per person. So you might have, let's just say, multiple lanes. So you might be doing 10 simultaneous vaccinations at once. So that is the variable we have to look at that would impact upon how much vaccines we can accommodate at once. Member BACCHUS is right. You have storage constraints, and then the very real issue of expiration dates. And I think that is our biggest concern. So in coming up with our mass vaccination plans, which we're working on, as CMO mentioned, that will give us a sense of what numbers we're looking at in terms of that utilization rate that we think we can manage as a public sector. So we don't have that figure just yet, member, but that's what we're working on in looking at our mass vaccination sites.
Okay, thank you. So really is one of those cases where it's the maximum limiting thing that will define it. You probably could, if you need to ramp up distribution, you probably could with the mass vaccination sites, but then you probably could only store 500,000, for example. So it's the maximum limiting factor that will determine where you, with what you do.
Sure. So through you again, Chair. So if I may, I think from our initial examination of the matter, our limiting factor would probably be ability to vaccinate persons. I think in terms of storage, we're pretty okay with storage in terms of existing capacity. I did mention we have been seeking to purchase additional capacity to ramp up our storage, but it's really the number of persons we can vaccinate. That is our limiting factor. So in terms of our discussions with the bilateral discussions, I did mention we're looking at indicative orders. That's just a quantum. That does not speak to the timing of that delivery. So for example, if we enter into a contract, just for argument's sake, for 800,000 doses, and our limiting factor is 300,000 at any one time, we will not order 800,000 doses at once. We will take it in batches of 250 or 300 as the case may be. So we're working on that, on those numbers as we speak with regard to the mass vaccination sites. Yeah? I trust that answers your question.
It does. Thank you very much. Thank you, Madam Chair.
Member Mark?
Yes, thank you, Madam Chair. I know that my colleague, Minister BACCHUS, had raised the issue about security earlier. I just wanted to ask the PS directly whether law enforcement, be it the Defense Force, the Trinidad and Tobago Police Service, because of the importance of this exercise that we are about to embark upon, both in terms of security storage and ultimately distribution and delivery, but more so in terms of storage of the vaccines. Would law enforcement, as opposed to private sector security, be responsible for safeguarding these vaccines at the two sites, that is Chagaramas and the Couva facilities?
Thank you, through you, Madam Chair. So we are looking at both a multi-pronged approach, and together with private sector, we have engaged the security, National Security, Ministry of National Security, and the various arms within that ministry to provide that additional support in terms of security.
And Madam Chair, may I ask, as we forward plan or we engage in what is called forward planning, can the PS or the CMO tell us what plans do we have for the distribution of the 140,000 vaccines that would come in the medium or short term, both in terms of WHO finally giving approval to or authorization to the Sinopharm vaccine, as well as those that are already approved by the WHO, that is the AstraZeneca. Could you provide this committee with a plan of a distribution of the 140,000 vaccines? How will these vaccines be distributed once approval has been granted and once they have arrived on our shores?
Through you, Madam Chair, yes, we can provide that information.
In writing?
Yes. Yes.
All right, thank you very much. Madam Chair, may I also join my colleagues? I know that we are in very difficult times, and I know that the CMO, the PS, and the team that they have with them, they are working extremely hard to safeguard Trinidad and Tobago. And as you have always said, we are here as a committee to see how we can assist and improve their efficacy, their effectiveness, their delivery of services, quality, as it relates to the people of TNT. So whatever we can do to help Mr. P.S. Ali and Mr. CMO, we will be willing to do so. So I would like to say in closing that whatever recommendations you would like to proffer to our committee through our chairman, feel free, so that when we are submitting our report, it will reflect the needs and the goals and the aspirations of this ministry in seeking to safeguard the health, well-being, and security of the people of TNT.
Okay, thank you. And I just want to ask a few questions just for some clarification. Mr. P.S., on again the budget, and it's, for clarification, when you give us the breakdown, vaccines and other consumables, Could you explain to us the difference between Oxford AstraZeneca 100,800 and the figure, and COVAX 10 million and the figure?
Sure. Thank you, Madam Chair, for that question. So I'm happy to clarify. So let me start with the COVAX figure first. That COVAX figure relates to the down payment that would have been due as part of the COVAX facility. So the COVAX arrangement spoke to countries making a down payment upon signing the agreement. So that's what that figure is for. The Oxford AstraZeneca, that's also part of COVAX, but that would be for the actual vaccines that we got confirmed dates for, of which 33,600 that we got yesterday as part of that 100,800. So the way it works with COVAX is that you make the down payment up front, and then as COVAX identifies a specific vaccine to be delivered to you, there'll be a cost attached to that vaccine, and then you pay for that vaccine, which is what we did in that case. Now, one might ask, what was the down payment for? So the down payment covers two elements. One would be an advance payment for vaccines, and it also covers some R&D, research and development. COVAX has committed to giving us, well, not just us, but all COVAX participants, the breakdown of how much of that down payment would go towards R&D and how much would go towards as a down payment for vaccines. Right. So what we did for that first shipment of the Oxford AstraZeneca, we paid in full for it. There was no offsetting of that initial 10 million on that because COVAX is still working out those figures.
Okay.
So upon finalizing that, when there's a cost for another shipment, they would then deduct some part of that down payment from that cost, and we pay the difference. I hope that explains it.
Very clearly. Very clearly. Thank you. The other thing I wanted to ask, Member Mark has asked about public partnership in terms of acquiring and procurement and so. In terms of deployment, I read, and I can't remember in what country, but it was in today's paper, where I think it's a state in the United States where they were deploying vaccines through the barbershop. Okay? Which made me smile because it reminded me of a model I've seen on that Netflix series that is raging in Trinidad and Tobago, New Amsterdam. So in terms of our deployment, I heard you talk about the mass sites, but is there any consideration of going into the community and using places like the barbershop to deal with issues of vaccine hesitancy? Would there be any consideration for that?
So I'd like to speak to that, please, Madam Chair. ROSHAN?
Yeah, so not at this time. I don't think Trinidad's distribution of vaccines has always been traditionally through the health system. The only vaccine, we have over 100 plus health centers which are all equipped to deliver vaccines to the people of the country. We can also deliver vaccines through the hospitals if need be. So I think our sites per capita is quite great. When we looked at the US model, for example, they had 600 sites for their full population. We have over 100 plus sites for our small population. So per capita, our access is very good. We have seen a model where the pharmacies, for example, a certain pharmacy in the country has begun a couple of years ago to distribute the vaccines through the private sector at their business places, but they have used physicians and or nurses to do the distribution. What it is that we are trying to do is err on the side of caution as it relates to clinical judgment and clinical security and safety for the patients to make sure that they have trained physicians really nearby and the ancillary staff as well as equipment in the event that something does go wrong, that we don't have any fallout from it. So I don't think at this point in time we'll be considering it, but in terms of access, the mass sites are akin to it, going outside of the public health system, which may be something new. But of course, we'll have to put these systems in place clinically and otherwise to ensure safety is there for the patients at all times. So I think we are okay in terms of access.
Thank you, CMO. And another thing I wanted to find out is in terms of when we spoke of the people outside of the public health system who have to, I call it register, but make an appointment. What would those people need to satisfy you all that they are in the vulnerable group? And when would they need to satisfy that? At the date of making the appointment or at the date they come for the vaccine?
So generally speaking, when you make the appointment, when you call to make the appointment, or if you walk in, they will ask you, of course, if you have an NCD, they may ask for proof of ID at that point in time. So there will be some process in place. If you're calling on the phone, of course, you take someone's word for it. They will tell you they're over 60, they have NCDs. When you come in and you're actually assessed, there may be persons who would have said they're over a certain age or have a certain disease that you may pick up, but we're asking the population to be honest because we want to deal with the most vulnerable at this point in time. Be truthful with your medical information to the healthcare practitioners as well.
Okay. Because that could also impact on wastage. Because
I don't think we will give it to someone who doesn't meet the criteria, but it may impact on someone being given an appointment, and then of course when they come in for the clinical assessment, they don't meet the assessment.
And that's precisely the point.
Yeah.
And therefore, having regard to that, so somebody, they made an appointment, they said they have an NCD, you think they qualify, they come and then they realize, okay, it's not truthful. So you don't give them. It means that you now have 1 short or 5 short. Is there built into the system a mechanism to ensure that, look, we can make up for that lost 5?
Yeah, certainly.
And how do we do that for it to be equitable?
Yeah, so as you know, the healthcare workers form a big part of the first phase. So because it's being delivered through the health system, the RHAs have that group of healthcare workers, and we ask that they use those individuals to buffer instances like this. So if they have, for example, need to vaccinate 5 more people, 6 more people, that they can get their healthcare workers to come in and fill that gap. So there's no wastage.
Right, thank you very much. And this, even though I think I know the answer, I think it's just to clarify the conversation. In today's Guardian, there is a story, vaccine rollout in Tobago begins next Tuesday. And the first paragraph says, on March 31st, an additional 3,000 2-dose AstraZeneca COVID-19 vaccines will arrive in Tobago. Is that correct?
So as Ms. Sibo would have said, I think earlier, so the allocation for Tobago out of the 33,600 will be 3,000. What we'll be sending across in the first instance will be 1,500, which will be half the allocation. And when we get to that point again, as we said before, based on expiry and everything else, ETA of new shipments, we will make a decision as to if they give the other 3,000 right away, the other 1,500 right away, or to give the remainder of the 1,500 to go towards a first dose. So that decision, but in the first instance, they'll be getting 1,500 doses.
Thank you very much. And one last question to you, Mr. PS, and this is based again on your budget, where the consumables, alcohol swabs and so on. And I think somewhere I read that you had already stockpiled things like syringes and so. Are those matters, the consumables, are they just specific to COVID-19, or are they going to be used in your measles, mumps and rabies and rubella vaccines and so on? Are these dedicated to COVID?
Thank you, Madam Chair. So the only item that is dedicated to COVID in there would be the alcohol swabs. The other items are used as part of our normal vaccination program for the other vaccines that you mentioned, but we have sufficient stock in place to cater for our normal vaccination as well as the COVID vaccination. All right, but the only item solely and wholly for COVID, the COVID vaccine, would have been the alcohol swabs.
Okay, and I understand you to be saying you certainly have to cover the 100,000 that you expect.
That's correct.
Or is it the 240,000? Which one?
Let me let Ms. Sibu speak to that because she's in charge of that. So I don't want to misquote. Anissa?
Okay. Thank you very much, PS. And through you, Chair, I just want to confirm that we do have enough to manage the 240,000 doses as quoted. We do have enough at this point in time, and there are incoming shipments.
Thank you very much. Okay, so might I ask the members if there are any further questions they would like? Member Bodu.
Thank you, Madam Chair. Madam Chair, I just wanted to follow up on the question that you asked in terms of the patients showing up on the health centers and so on. In CMO, I just wanted the public to be clear as to what happens on Tuesday morning. They have 21 centers. Is it that by Tuesday morning, those who are to receive vaccines will be identified and will be expected to show up at those centers? And so, for example, if I just look at my constituency, Siparet District Health Facility is a designated center. If you have chronic patients at Oropuch and Faizabad Health Centers, will the arrangements be made? Is that going to be communicated to the Siparet District Health Facility? I'm just using that as an example. So I don't know if you want to provide further clarification on exactly what the population can expect on Tuesday morning. CMO?
So on Tuesday morning, we expect that there will be certain health centers that already have their NCD clinics, meaning that if you have an appointment for an NCD clinic, you show up as usual for your NCD appointment. You will be offered once you meet the criteria over 60, having an NCD, you will be offered by the staff there to have the COVID vaccine. Remembering it is a voluntary process, so you'll be offered and then given if you say yes. The other category of people that will probably be coming in on Tuesday morning based on appointments made by the RHAs would be healthcare workers, as well as we don't expect, and we expect people to come in, maybe walk in or call on Tuesday to make an appointment for further down the line. So that will happen. Of course, you'll be made aware of all the numbers within the next day or two as to where to call. You can walk into your health center once it had been one of those 21 centers to make an appointment as well.
So each of those health centers will have their own NCD clinic, which is normally one day of the week.
But normally 2 days a week in most instances.
2 days a week.
Yeah.
So the other 3 days are still going to be utilized for vaccinations, but those patients will from where?
So they will be from the healthcare workers, one, and from other persons that make appointments.
All right. And with the other health centers, with the NCDs, with the NCD clinics that are not being utilized, will there be some sort of referral system from those clinics? I don't know if you understand it.
Yes, so the RHAs do have the discretion to actually reach out to those populations and bring them into that facility or ask them to come to that facility or make any other arrangement that they see fit to have those persons vaccinated.
All right. I think that's clear enough. I don't know if Ms. Sibu wants to add anything here at all through you, CMO.
Yeah.
In terms of how that arrangement is going to be strengthened.
Sure.
Hi, good day. Thanks for the question. So with respect to the other days of the clinic, the days that there are no NCD clinics, like CMO would have mentioned, there would be the arrangement within the RHAs so that they can inform, it will be a reference from the other health centers within the area that they can refer their patients, their clients to, so that they can get an appointment to have the vaccine at those sites, at the selected sites. So take, for instance, the Siparet District Health Facility. Being that site, we have Palisaco, we have Pinal for that in that catchment area. So those things are going on as we speak right now, because we do have persons on the ground level there doing that bit of collaboration. So that is the intention, and that is what is happening right now, and that is how it's going to roll out.
Thank you. That's the answer I'm looking for, that it's actually happening right now. That is what you're saying.
Yes.
Yes. Okay.
Yes.
Thank you. Thank you, Madam Chair.
You're most welcome. Thanks.
Member Webster Roy.
Thanks, Madam Chair. I just want to clarify, would the hours be extended or regular hours at the 21 centers? for the purpose of the vaccine distribution? Would be extended hours or regular hours?
So in the HASSELL, yeah.
So initially there'll be regular hours. Through your chair, there'll be regular hours initially, but of course, as we go along with the vaccination exercise, if there's any extended hours, we will definitely look at that in terms of doing extended hours.
And your regular hours, just Mr. Ali, for the public, 8 to 4?
8 to 4, Madam Chair, yes.
Thank you very much. Member Dunarine?
Thank you, Madam Chair. I just have a follow-up question with respect to persons in the NCD clinics, right? Now, you know, you all mentioned that there is a expiration date on the vaccine. Now, some of those clinics don't necessarily reschedule or meet again until that expiration date. So sometimes the scheduled appointment might be 2 or 3 months down the road. How persons who volunteer to take the vaccine and then don't get an appointment later on, how is that going to be dealt with to get the second vaccine?
So everyone that has the first vaccine will be given an appointment for the second vaccine. And of course, it will be prompted by the system by way of email and text message as to when that second appointment will be.
And also one other question, I don't think it was mentioned during the discussion just yet. No, we luckily have not received any cases of the variant of the COVID-19 virus. In the event that we do get a case of that variant, I think they call it B117, if I'm correct. What is our plan of action in such instances, and would the vaccine still be effective?
Well, we had one case of the B117, which is the UK variant, in a repatriated individual that was typed by the University of the West Indies and announced about a month ago. That case was repatriated and stayed in quarantine for upwards of 30 days to ensure that the person became negative before they were discharged home. So really and truly is really preventing those individuals from coming into and mixing with the general population through border control strategies is the primary goal, to keep it out of Trinidad and Tobago. Knowing fully well that one, they have been proven to their variants of concern from South Africa, from Brazil, from different parts of the world. They have been proven to be more virulent, meaning they are more severe disease, they cause more severe disease, and they are more transmissible, meaning they pass from one person to the next very quickly or more quickly than the non-variants. So it is very concerning. It will be very concerning if we do have variants of concern coming into Trinidad. Hence the reason we have that stringent quarantine measures in place to prevent that. And they have been actually shown to decrease the efficacy of vaccines as well. So we maintain our quarantine protocols to ensure that the variants don't come in and attempt to get our population vaccinated as quickly as we can so that we have that level of protection hopefully before the variants ever come in.
Okay, thank you.
Okay, and therefore I just want to ask 2 or 3 other questions. P.S. in a discussion earlier with Member Mark, when he spoke about talks with President Biden and gifts from the United States of America to Canada and Mexico. I know certainly in the case of United States and Canada, it's not a gift. I think it has been described as a loan, right? Which means Canada has to give it back. With respect to China and India, is this a gift, as we understand, in our parlance, meaning we don't have to give it back, or is it a loan?
Madam Chair, it is a gift based on correspondence received from both embassies through Ministry of Foreign Affairs. It's a gift in both cases. Right,
thank you very much. And in respect to, I know the CMO would have said that in terms of us going ahead with AstraZeneca, we're not too concerned about the low incidence of clots that have occurred in places like Germany and so on, because there's not enough data to show that is as a result of the vaccine. But having regard to information in the public domain, how do we treat with that in our communication strategy? And how do we treat with that when we interfacing with the individuals in the clinics who we are saying is voluntary, and how do we treat with full disclosure as regards the incidence of clots?
Madam Chair, let's see, maybe please see everyone, Candice.
Yeah, sure. So I could start, and then Candice could go into the communication strategy. I mean, we have been trying to present the data in a way that is that at least the population can understand what is going on. We would have had a media sensitization exercise last week, Friday, where the matter of responsible reporting came up, and of course was discussed transparently. And I think we would have had an incidence, for example, when a physician would have died a month or so ago in the US, and there were queries related to blood clotting as well. 2 weeks later, it was proven that there was no link between the vaccine and that individual dying. And there was no follow-up call or carry on in the media to really back up that and allay the fears of the population. So, I mean, it really lends itself to the Ministry of Health having to go forward and have this communication campaign to, in terms of myths, and make sure that people know the facts. And we have developed an FAQ as well as a common myths brochure, and Candice can go into detail so that we can disseminate those in the first instance. Of course, our press conferences are there, hoping that people ask the pertinent questions and we are able to explain it so that the general population can understand and know that the risk is not there. But again, it really is reliant on a heavy corporate communication strategy. So, Ms. Alcantara, I don't know if you want to add.
Thank you.
Thank you very much, Chair. One of the key messages is why get the vaccine? Actually, it's interesting. Your question is interesting because we did discuss that in our meetings with UE. The strategy we're taking, for example, for the public campaign is that we're getting video snippets of members of the public asking questions, and our key experts will answer. We have agreed that the question on why should I get it, we will include the matter of variance in there. Variance is one of the areas that we will focus on as well in social media, because we find that medium is especially helpful. As it relates to the conferences, while we do not have as much viewership live during the conferences, people are back out to work. What we are seeing is that the media is reporting on the content from the conferences. And I'm quite happy because it helps me save money when they report every Monday, Wednesday, and Saturday. And so we've included variants and vaccine discussions, especially with Professor Carrington from UE. She really gets good reviews on social media when she's on the conferences. So we've included it into our messaging. I hope that helps.
Okay, and I have one last question which we've received from a member of the public, and is given the unique situation, where do Venezuelan nationals authorized to stay in Trinidad and Tobago fit into the distribution of vaccines?
Okay, thank you, Madam Chair. They fit in once they meet any of the 3 criteria that we mentioned during the course of our discussion. Healthcare workers over 60 persons with NCDs.
And that goes to anybody residing in Trinidad and Tobago.
That's correct, Madam Chair.
Right. Thank you very much. So I again turn to the members of the committee to find out if there are any further areas that you may want clarification on. And if not, I would then just say to the PS, again, echoing some remarks of Member Mark, maybe you could tell us how you think we can help you. Okay, and if you don't have that right away, as you know, we continue the discussion in writing, and maybe you can say how you think we can help you.
Sure. Thank you, Madam Chair. So definitely we will put our suggestions forward in writing, but definitely one way you have helped us, you and members of the committee, is by allowing us to share with the committee and the public some of what we're doing. It would have helped to clarify some issues. We spoke about vaccine hesitancy, some of the myths around vaccines, clarified our rollout plan. So thank you to the members of the committee and yourself for allowing us to be able to share with the public what we're doing with regard to vaccination. Thank you again, members, for the suggestions and the recommendations. We will definitely take those on board. And if we have any specific requests for assistance, they will definitely be included in our response to you. Thank you very much, Madam Chair.
So, Mr. PS, Mr. CMO, the principal pharmacist, the two deputy PSs, the director of health and policy, your project manager, and your manager of corporate communications. On behalf of the committee and on behalf of the wider Trinidad and Tobago, I want to say to you all, thank you very much for this very candid discussion. I also want to take this opportunity to thank you all for the health of the nation in terms of having managed this pandemic and having been so responsive. I can't say personally how happy I was to see that plane land yesterday, because the proof of the pudding is in the eating. And I wish you all the best for Tuesday and onward. And particularly to Ms. Alcantara, tomorrow, you see that communication plan begins. Tomorrow can't come soon enough. Okay, so again, thank you very much. Thank you to the members of the committee. Thank you for the members of the listening public and the members of the media who stayed with us and listen. Media, you know, we rely on you to responsibly carry on the conversation. Okay, so good evening. And this part of the meeting is now suspended. Thank you.